Good morning. Good morning, dear colleagues. Welcome to a first session of Saturday. This session is opioid and multi-drug addiction in patients. Welcome to Dr. Eli Alon. He is online. He's the chairman anesthesia of University of Zurich for several years. Welcome to Dr. Alon.
I'm happy to be here as your co-chairman in this session of opioid and multi-drug addiction in patients. Thank you.
Thank you, Doc. Okay, the first presentation invite Dr. John Pepin. Dr. John Pepin is internal medicine and professor of palliative care and hospice in USA. Welcome, Dr. Pepin.
Thank you very much. Buongiorno a tutti voi. And I'll jump right in since we need to catch up a little bit. I want to talk a little bit about what's called the opioid crisis in the United States, and it does relate to just about everywhere else in the world, and you'll find out why I feel that way. A sinistra. Huh? First, let's start with the case study, and this is a true case that a good friend of mine, Dr. Josh Gunn, presented to me. So we have a 70-year-old female who was found dead laying on her back in the kitchen. She had dishwashing gloves on her hands, sink water was running, unfinished cup of coffee on the sideboard, no evidence of foul play or head trauma or anything like that. She had a long history of coronary artery disease and had a past history of a myocardial infarction. Distantly, she had a history of trauma with multiple vertebral fractures, had chronic pain from that, and had been placed on morphine 30 milligrams twice a day, and had been on that dose for over 5 years, and it was stable, and she had seen the same pain doctor for that time. This morphine kept her comfortable and functional, no personal or family history of substance use disorder, and again, she'd seen the same pain physician for over 6 years, no issues. The death certificate initially said myocardial infarction due to coronary artery disease. Anybody disagree with that based on what I've just presented? No, I don't think so. However, the coroner reviewed the case. He drew central heart chamber blood, and morphine was found to be at toxic levels. He changed the death certificate to morphine overdose. Now, the problem with this, of course, is that now the family loses a life insurance, there's reputation, there's all kinds of other financial issues that come with it, but the death certificate was changed to morphine overdose. So what are the issues in this very short case? First thing is the coroner qualifications, we'll talk about that. Death certificate data entry, we're going to talk about that. And misunderstanding of opioid drug levels. What's toxic, what's not, and when? Questionable post-mortem blood draws. Was this a good place to be drawing blood, and why it might have changed the results? And we'll talk about that. We're not going to talk about the ICD system weaknesses, but there are significant weaknesses in describing overdose deaths. Dr. John Coleman and I have published on this twice, and we have a third paper coming out on this topic as well. But wrong data added to the crisis opioid overdose numbers. So there you go. This woman who probably died from myocardial infarction is now an opiate overdose. Now, the crisis in the US is defined by data, and data comes from numerous sources. Death certificates are the primary source. The National Household Survey, which has lots of weaknesses, CDC data, et cetera, we could go on. But all these sources have strengths and weaknesses, and we rarely discuss their strengths and weaknesses. As far as overdose death, it's the death certificate that defines this data. And how accurate is that? Well, let's talk a little bit about that. The death certificate was originally set up many years ago, hundreds of years ago, to help establish estates. So if someone died, where's that estate going to go? Where are the monies going to go, or whatever else that individual had? So it was settling financial issues, and then evidence in court cases, and since then it's developed into becoming the defining factor in success at life prolongation. So it's the primary tool around the world in defining how that particular culture does well at life prolongation. Helps set international, national, regional, statewide policies. Funding and interventional approaches all can come from that death certificate data, and major research studies as well. Mortality statistics derived from the death certificate is the most widely used health data source at all levels. And the data goes from the death certificate, where someone enters a cause of death, goes to state vital statistics office, then to the national vital statistics system, and then to the international WHO system. So it has a long process, and at each point there's potential for errors. We won't talk about each of those, but we'll talk overall about entry and data. But the WHO plays a major role in this collection, classification, tabulation, and expression of this data, and that's the ICD system, which is poorly designed, if you will, to describe polysubstance overdose death. It may be well defined for other things, but when it comes to overdose deaths, it's poorly designed. So who fills out the death certificate in the United States? Well, physicians, medical examiners, coroners, funeral directors, and others, depending on the state. Does not have to be a medical professional. It, again, depends on the state. This is similar in Canada and the UK, and as far as in Italy, as I understand, only a medical professional can specify the cause of death. Traditionally, it's presented as one underlying cause. So the data can be augmented in a Section 32 of the death certificate, but you would have to write down oxycodone overdose death or morphine overdose death, and that would be the primary cause. And we'll talk more about that in a second. Opioid overdose deaths is significantly overrepresented as a cause of death when an opioid is present. So if an opioid is present, frequently it's going to be an opioid overdose death, just like our case study. Just like our case study. And I think no one would disagree that she died of a heart attack, right? In an ironic twist, probably no document has as much impact on the health of a population as does the death certificate. Recent studies have found many inaccuracies in these certificates, and their reliability has come under increasing criticism in medical journals and among health officials. This statement was made in 1988. You can find statements going back to the 1800s saying similar things. We've known about the error rates in death certificates for 100 years. So, why haven't we changed things? Well, that's a good question. But physician ignorance is part of the problem. Lack of training. When I was in med school, I didn't get any training in filling out a death certificate. And the first death certificate I filled out got returned because I put the wrong thing. I was like, well, what do I put? I guess their heart stopped, so I'll put coronary artery disease and heart stopped. But we lack that training in med school, and we lack it in residencies and fellowship as well. There's a lack of understanding of drug overdose deaths, a lack of understanding of polysubstance overdose deaths, and of course the ICD-10 codes. Dr. Coleman and myself have published on this. There's also political pressure, which is very interesting. So for example, just as an example, in Puerto Rico, during Hurricane Maria, the official mortality was 75 times less than actual survey results. So they just didn't want to express the fact that they had so many people dying from that hurricane. So as far as errors are concerned, and I could give you a whole 20-minute talk on the articles around the errors of death certificates, but just a few examples. Pritt in 2005, multiple errors were identified in 82% of the death certificates that they reviewed. McGivern in 2017 in Vermont, 601 death certificates, error rate was 53%. Wexelman looked at residents and found that 46.5% knowingly entered inaccurate data into the death certificate, knowingly now, and only 33% of those believed that the cause of death data was accurate. Think about that for a minute. Brooks in 2015, only 15.5% of the physicians that they queried with some case studies could correctly identify the cause of death. That makes you step back. Now, it's not just the US. Similar error rates in Canada, in Nepal, and in Italy. are all expressed in the literature. There was a quote recently from Robert Anderson, who was chief of the branch of the National Vital Statistics Center, and he was quoted prior to COVID that 1 in 3 death certificates was wrong, it's a word he used, and suggested that things were going to, quote, get worse, unquote, after COVID really hit. So even the CDC and the government agencies admit that we've got a significant error rate. But there's very little data on others who fill out the death certificate other than physicians. For example, funeral directors in some states, or judges, for example, in Texas. How accurate are they? We don't know. And how common is that? We don't know that either. So let's talk about the coroner and medical examiner. The coroner, at least in the United States, is an elected official. They don't have to have any health care or medical requirements generally. There are 4 states that require coroners to be physicians. The coroner decides if an autopsy is necessary, that's not required, and only 16 states have laws specifying coroner training requirements. As an example, in Georgia, in the United States, the coroner position is elected, and this is what they have to have. They have to be a registered voter, over 25, no felony convictions. I always found that kind of interesting. High school diploma, and 1 week of annual training, which is not specified, and they have to have that training every week. One has to wonder that this is the individual who's filling out the death certificate in cases of overdose deaths, for example. What are their qualifications and how do they understand those things? It's concerning. Medical examiners, most are appointed and not elected, must be a physician. Most states do not require pathologists or forensic pathologists to be medical examiners. And only 1 state in the entire United States has medical examiners in all their districts, and that's the state of Florida. So, coroner system is around the world. It's in England, Wales. Studies comparing different interpretations with case studies show little consistency on cause of death from those scenarios present. And if coroners cannot agree on what caused a person's death or whether the death was even reportable or not, then the desired prevention for future deaths becomes a difficult task. I think that says much. In Italy, there is no official death investigation agency, such as a coroner or medical examiner system. And misdiagnoses are inevitable in Italy. Divella said the same thing in 2015. So it's around the world. Wherever we are, there's significant problems with expressing death data. Now let's talk about opioid overdose. And this is an area that gets quite complicated because I think most people would say, well, it's OxyContin, it's morphine, it's whatever it is. That's just not the case. Back in 2003 and 2004, Cone did 2 excellent reviews looking at patients who had died and been classified as an OxyContin overdose deaths. Majority of those cases involved multiple drugs, benzodiazepines, illicit drugs, alcohol, etc. In New Hampshire in 2015, 72% of the fentanyl-related cases had polypharmacy involved. And when opioid prescription is detected, it's a prescription now that you're being given for pain, then it's a prescription opioid overdose death is frequently listed as a cause of death. So do we have a prescription opioid problem or a polypharmacy overdose problem or abuse problem? Frankly, I think it's a polypharmacy problem, but that's my thought. So what about post-mortem fluid specimens? I mentioned that in the case study that we had. These are frequently drawn by medical examiners, also by the funeral director at the funeral home, coroner, others, and they can do peripheral draws, vitreous collection, urine, etc., but frequently it's central heart chamber blood. And why is that? Because it's an easy draw, right? The patient's died, you can easily get into the heart and draw some blood. But this is notorious for post-mortem redistribution effects. So this can falsely elevate ante-mortem levels to toxic levels, and it can be significant. This is rarely discussed, and it's really fascinating. And Dr. Josh Gunn, who I mentioned, has lectured on this around the world. It's a significant problem. Oh, sorry. And this reliance on opioid blood concentrations compared to predetermined fatal cutoffs, ranges are obtained through PK/PD studies when they're doing clinical trials, and these are healthy, non-opioid tolerant subjects generally. So really, these fatal cutoffs have little meaning, and just to show you really quickly, methadone, for example, Basalt in 2000 found these four ranges of fatal ranges of methadone, right? But if you look at studies on patients taking methadone for opioid use disorder, look at the range they have. All of these would be declared dead if we use these fatal ranges up above. And obviously they're not, they're functional. So we really have to sit back and say, wait a minute, let's think about what we have and what it means. So no difference between methadone blood concentrations due to toxicity or when methadone was found as an incidental finding, which is what I said in the previous slide, really. Morphine concentrations in current heroin users, you know that morphine is a metabolite from heroin use. And heroin overdose deaths, concentration overlaps. Morphine concentrations in deaths ruled morphine toxicity compared to those homicide with incidental morphine, no difference between the two groups. And I could go on, there's just a very large literature on this. But with fatal toxic concentration levels being so broad and overlapping with ranges that many addicts live with, a toxicology report is of little help with determining the cause of death. That's a pretty powerful statement. But I think you have to step back and say, what's the clinical scenario? Just like the case study. What was that clinical scenario? She'd been on that medication for 6 years. So obviously it wasn't a morphine overdose death. Okay, in conclusion. I talked about complexity yesterday, and I harp on this because it's so important, and many of the lecturers in this conference have talked about the complexity of chronic pain. This is a critical issue. It's ignored, in my opinion, by CDC guidelines. It's certainly ignored by the media, regulatory agencies. If you've ever been to an FDA meeting, anyway, it's kind of interesting, but as far as the complexity of chronic pain, they don't get it. And single answers are rarely effective in the chronic pain patient, whether procedures or medications. So that's the first problem that we've talked about. And I showed this yesterday of the number of things that impact pain levels in patients that are in the literature. And it's obviously very complicated. So what would we recommend, or I would recommend, John Coleman and I would recommend? First of all, I think the coroner system is outdated, it's inefficient and inaccurate. We're not the first ones to say this. There have been multiple articles about this. And also, this would be a very complicated system to change. But I'm just saying, if we're going to have accurate data, if we want accurate data about opioid overdose or COVID deaths, by the way, then we need people who understand this system. So I think it needs to be changed. And I think ideally they should be forensic pathologists. Databases. We should understand the strengths and weaknesses of these databases. And the media should be held accountable for reporting things from the National Household Survey, which I think is a very suspicious database. I mean, when you're asking a 12-year-old child what drug they misused, and you're showing them pictures of drugs, some of which haven't been on the market for 30 years, one has to wonder about the results of such data. What about death certificates? Well, they shouldn't be filled out by non-physicians, in my opinion. And we should be trained, all of us trained. I learned how to do this on my own. I was not trained to do this, as many of us have. And that training needs to be in medical schools, residency, fellowship. In my opinion, I think the medical education system has been a gross failure in the areas of pain medicine, palliative medicine, addiction medicine, and cause of death reporting. I'll leave that as that. As far as CME, what is continuing medical education? And this needs to do what? Change behavior, right? That's really what we want to see. Unfortunately, I think CME is also a failure for lots of reasons, and it's become very structured to the point of being fairly useless. As I say that standing up here giving a talk that's getting CME credits. But what about evidence-based outcomes? So the guidelines, for example, the CDC guidelines, they had no evidence-based outcomes from those guidelines. They just threw the guidelines out there. And it ended up becoming almost legal documents in a lot of ways. People were actually lost their licenses if they didn't follow the CDC, quote, guidelines, unquote. And we had a good talk about guidelines yesterday. But policies, regulations should have built in my opinion, evidence-based outcomes. None of the previous things that I have said is meant to diminish the opioid issues that we have in the United States. We have overused prescription opioids, and it was clear to us who did pain medicine at the early onset that this was not the panacea for chronic pain, and that there were a lot of problems with opioids. I don't think we should throw the baby out with the bathwater, as we say in the U.S., because I think opioids have a place. But having said that, we certainly overuse them. We've approached chronic pain very simplistically. All we need to do is an injection or give them a pill, and that's all we need. Well, obviously that's not true. We have not treated chronic pain patients with multimodal, multidisciplinary, multitherapeutic approaches. I think we've ignored the issues of substance use disorders, where people seem to think that if you take an opioid, you have addiction. That's not true. So what is addiction? What's substance use disorder? There's a big difference between that and taking a medication for a specific reason. We've poorly treated pain, we poorly treated substance use disorder. And as ending, just since we're talking about death certificates, Romanian court rejected a man's attempt to persuade them that he was alive. So this individual tried to convince the court that the death certificate that said he was dead was incorrect. But the system said, you know what, you've already been declared dead, so we're not going to change it, you're still dead, even though he was clearly alive. So it's not, these things can happen all around the world, and he would be silly like this. Thank you very much. Grazie mille.
Thank you very much, Dr. Pepin, for excellent presentation. The next speaker is Dr. Joseph Pergolisi. He is Naples Anesthesia and Pain Management. He will present the topic to us, abuse of benzodiazepine and pain management. Welcome, Dr. Pergolisi.
Buongiorno. My name is Dr. Joseph Pergolisi, and I'm joining you from beautiful Naples, Florida, in the United States. Today, we're going to talk about abuse of benzodiazepines in pain management. These are my disclosures. And here are the learning objectives. We're going to try to walk through this, and really it's to stimulate thought and conversation amongst all of you as the rest of the day proceeds at this wonderful Congress that I commend Dr. Verassi for putting together. And I'm very humbled to be with you. Well, it starts with a book that I would suggest. Dr. Pippin is with you, and you've heard from Dr. Raff already. Myself and Dr. Wright helped write this book on benzodiazepines, really that looks at the ramifications of an overused drug class. And we'll try to put some of the highlights of that here, but the book obviously is more in depth, and I think is a nice book to have as a handbook. So where do we start? Benzodiazepines have been around for a long time, and we could do as I did when I was teaching physical chemistry, and take a very long, pragmatic, didactic trip together, or we can do as Albert Einstein said. You don't really understand something unless you can explain it to your grandmother. So we're going to try to use the KISS principle and keep it simple and short. Let's look at pain and anxiety and why we need to worry about this as pain doctors. Well, pain is still the #1 reason why people seek medical care. A high prevalence of chronic pain is observed among the adult general population, and associations between chronic pain and mental disorders are frequent. Psychological comorbidities are common in patients with chronic pain and have a high prevalence of depression, anxiety, and other psychological conditions. So patients experience anxiety disorders and pain quite oftenly. And patients who have anxiety disorders report significantly worse pain and health-related quality of life than patients without similar disorder. So what are some of the myths and facts related to benzodiazepines and Z drugs? Let's look at some of those. First, myth, benzodiazepines are first-line therapy treatment for anxiety. Well, that's not true. They may be used for 2 to 4 weeks to treat severe symptoms of anxiety disorder, ideally while waiting for the full effect of other treatment options, which include non-pharmacological ones. And the diminish in their effectiveness is seen beyond 4 to 6 weeks. But it's not uncommon that we'll see patients on these anxiolytic drugs that have been on them for years. The next one, benzodiazepines are first-line treatment for insomnia. Well, again, they're for short-term, 1 to 2 week symptomatic release of severe insomnia, while other treatment modalities are being implemented. They can cause rebound insomnia once stopped, and they don't appear to be effective for chronic insomnia. How about low-dose benzodiazepines are not a problem? Well, that's not true. Benzodiazepines can result in physical dependence at any dose with prolonged use. The Z drugs, like zolpidem, are totally safe. Now, this isn't true. They're not recommended for long-term use and offer little safety benefit compared to benzodiazepines, particularly in elderly patients, particularly when it comes to falls. This here is a list of commonly prescribed or available benzodiazepines and Z drugs in the United States, and I think similar in Europe as well. And you see that they can be based on the elimination half-life, they can be based on the class of drug itself. Why is this important? Well, the population pyramid across the entire globe is upside down right now. There are more people entering into their 60s and more people becoming octogenarians. And what we're finding is that these individuals are having particular issues with sleep and even sometimes anxiety, as well as pain. And so we need to be aware of that. When we look at the adverse effects of benzodiazepines on the elderly, what we find are the following: that benzodiazepines may contribute to psychomotor impairment and increase the risk of falls and automobile accidents. This is related to slow reaction time and diminished speed and accuracy of motor skills. The risk of falls has been associated with the sudden increase in dosage and with continuous use of benzodiazepines. And benzodiazepines with shorter half-lives appear to be no safer than the agents with the longer half-lives. The Centers for Disease Control data in the United States acknowledge that we're commonly prescribing opioids and benzodiazepines, and these are to the same patient. So how does that happen? Well, it may not be the pain specialist who's writing both prescriptions. And it's not uncommon that maybe the primary care doctor is writing for the benzodiazepine and the pain doctor is writing for an analgesic. And that has to be acknowledged, and that's why it's very important that you do routine inventory or pharmacy inventory of what your patients are taking in order to understand this better. So understanding the comorbid diagnosis is important, and understanding who's prescribing what, because this can result in multiple adverse outcomes, including fatality and overdose when we combine these agents. This has been so important in the United States that the FDA actually did a class-wide label drug change, highlighting the serious risks associated with the combined use of certain opioid medications and benzodiazepines. And that's very important. Now, these warnings and precautions include profound sedation, respiratory depression, coma, death, which may result from concomitant use of opioids with benzodiazepines and other CNS depressants. If the decision is made to prescribe, then you want to prescribe the lowest effective doses and minimal durations of concomitant use. And you want to follow the patients closely for signs and symptoms of respiratory depression and sedation, and also alert their family members to be aware of that. If we look at the epidemiology of benzodiazepines, what you'll find is that the percent of population with any benzodiazepine use by sex and age in the United States is shown here. And this is a little older data, and actually the prescription volume has gone up. But you can see that it's really that age group, particularly elderly, that we have to be very even more concerned about. And why is that? Well, emergency department visits involving benzodiazepines in combination or alone have been increasing year over year. Here's some older data, and this includes patients anywhere from the age of 12 years and older. And notice that when we look at the number of those visits for benzodiazepines alone, it's very high, even in 2011. And this is when there was less co-prescribing. So I'm going to show you some more common data. But it's important to realize that this can be problematic. Now, why am I showing this? Well, this is 2010 and 2014 data. There's 2016 and 19 data that I could show you too. And what's common here is that the fourth place for the leading drug for overdose deaths in the United States has stayed steady with olanzapine, that being a benzodiazepine, right? The number one and number two culprit from the opioid may change. So that position has been fluctuating. As you see here, oxycodone, heroin, now it's illicitly manufactured fentanyl. But what stayed steady is the benzodiazepine, and that is true with the latest data in 2019 from that same study group. Now let's look here at the number of adults filling benzodiazepine prescriptions, the quantity filled and overdosed involving benzodiazepines, and what you find again is that you have this increasing number, and it's even higher due to COVID, the horrible pandemic that we're all struggling with, because of the anxiety that was related to these patients who may have been on different types of analgesics, or even if they weren't pain patients. So this is a very interesting article I thought I'd share with you, because this article here really started to look at the fatal and non-fatal overdoses involving benzodiazepines in the United States and the District of Columbia. And what did we see? Well, the number of benzodiazepine overdoses and co-involved opioid overdose emergency visits is staggering. There was a slight dip when we looked at this, but what we find now is the numbers are even higher. And that dip may have just been really reporting because of the prevalence of COVID and how it really overwhelmed our emergency departments. But when you look at this data a little further, it really didn't have much of a difference between sex and age and other types of separations. And here he shows the benzodiazepine deaths with opioids as co-involvement, and those both include prescription opioids and illicit opioids like heroin in the United States and illicitly manufactured fentanyl. So it's really a concern in the United States. And at the result of this MMR report, what do we come out with? Well, benzodiazepines involved with opioid deaths decreased 2017 to 19. However, since 2019, illicit benzodiazepine supply has increased, and that's had a tremendous input. So potentially here in the United States, the box warning might have had a positive effect, but certainly with the flooding of the market of illicitly manufactured benzodiazepines, we've had some major issues. And if you look here during January and June, you find that there was an increase in benzodiazepine involved deaths, and also that involved opioids and involved illicitly manufactured fentanyls. From 2019 to 2020, benzodiazepine overdose visits per 100,000 emergency room departments increased, and prescription and illicit benzodiazepines were involved in those overdoses, respectively. So as we start to look closer at adverse events of co-prescribing, notably overdose, it's important that every one of the FDA commissioners, including Dr. Califf here, says that it's nothing short of a public health crisis when these two widely used classes of drugs are taken together. So when we're able to control that, again, we have to use the lowest dose for the shortest amount of time, and it should really only be one prescriber, right, that's giving these prescriptions. Now, when we look at the big picture and it comes to practices to try to improve benzodiazepine prescribing, we can learn a lot from the opioid crisis in the United States, and hopefully that can at least give some positive information to the rest of the world to think about. You know, so what have we learned from the opioid crisis here in the U.S.? Well, broad education and awareness is needed at all levels. And all stakeholders need to be involved when creating these safe use initiatives. I applaud the FDA for having an opioid safe use initiative, as well as the VA health system in the United States. And when you design these types of programs, you have to use the KISS principle. You know, keep it simple and keep it short so that people can understand. Remember, health literacy is a problem. And health literacy has nothing to do with being illiterate. So we have to keep it so that it's manageable and people understand. And all stakeholders need to be involved. And appropriate prescribing and appropriate consumption, that means both sides of the spectrum, what we're writing and what the patient are taking. So again, we can learn these lessons. We have to understand that, unfortunately, polypharmacy and polysubstance issues do exist. And what's even more troubling is that when we think about community-based efforts to assist a person who's overdosed in the United States, we're really left right now with opioid antagonists, which are 50 years old. They weren't really designed to combat illicitly manufactured fentanyl at the dosing that we originally discovered these and got approval for them. And that's why you're seeing newer sort of routes of administration and higher doses for naloxone out there. But we do not have an agnostic respiratory stimulant for polysubstance drug overdose. And that's very concerning, right? Because when you look at the numbers I just showed you, you're seeing that polysubstance or polydrug overdose is a big problem, and it's leading to deaths in the United States. So we need to be cognizant of that, and we need to take our efforts and focus them on developing alternatives so that they're either working with naloxone or they're addressing the other type of CNS respiratory depressant agents like the benzodiazepines, alcohol, gabapentinoids, etc., that patients are being either co-prescribed or using illicitly. And some companies are out there doing that, and I applaud them for it. I know I'm working with Dr. Rafa on one of these agents, which is a agnostic respiratory stimulant, and we're very hopeful that what we've seen so far will continue. And we thank the efforts of Dr. Albert DeHaan, who many of you know, and Dr. Verase, Dr. Famila Kaluzzi, and others that are helping us try to bring these very, very important compounds out. So one thing we can take away, and it'd be great for all of you to talk to each other about the legal, regulatory aspects. In the United States, you know, certain drugs are scheduled, right? We need to think about the duration and the dosing of these agents. As I told you, it's not uncommon that people are on these for a very long time. What about dependency? You know, Dr. Raffer, I think, will talk a little bit more about this when you speak with him, when you hear his lecture. But there's a lot of different things that we're learning about what we need to do to better utilize this important class of drugs in an appropriate manner. Remember, pain is a terrible lord of mankind, that even death itself. And so we want to be able to manage our pain patients. We understand that psychological issues like anxiety, psychiatric issues come hand in hand with our chronic pain patients and high comorbid index. So we have to be able to use multimodal and multi-mechanistic strategies to manage their pain and appropriately manage their anxiety. But we have to do this in a safe and effective manner. And that includes, as I mentioned, a multimodal, multidisciplinary team approach to provide the best outcomes for our patients. I'm sorry I'm not there to ask any questions, but you can certainly email me. And again, I want to thank all of you and wish you a very, very nice rest of the Congress in the Eternal City. And I look forward to seeing you there next year. Thank you.
Thank you very much, Dr. Pergolisi, for excellent presentation. I want to give the microphone to Dr. Eli Alon to coordinate the following lecture and discussion. Please, Dr. Alon.
Kind presentation. I'm Dr. Alon. I'm in the University of Zurich, Switzerland, and in the moment I am in my vacation place in Tel Aviv, in Israel, and I'm happy to present here the next speaker is Dr. Robert Raffa. Unfortunately, also a recorded lecture, but will be a good lecture on the need of an agonistic drug to treat overdose. So Please, we would like to see now the presentation, and we have the possibility for the discussion at the end.
Well, thank you very much. First, want to thank the organizers for putting on this very important session, and also the chairs, Dr. Alon and Dr. Tamayo. What I would like to talk about is what we're calling the need for an agnostic drug to treat overdose. And I'll explain what we mean by that. Now, clearly, first, in way of disclosure, I'm a co-founder of Enalair Therapeutics, which is developing novel therapies to treat drug-induced acute respiratory depression. Now, respiratory depression is a big problem. I think everybody is aware of it in terms of the community setting. Overdose deaths are at an all-time high, increased during the time of COVID, and continues to increase. But also in the hospital setting, also at all-time high numbers. Here we're talking mainly about respiratory depression associated with surgical procedures. There are many more now than there used to be, and they're being performed on more at-risk patients. So it also is becoming a bigger problem. It's getting worse, as I mentioned, because of many reasons related to socioeconomic reasons as well as COVID. And very importantly, really when we talk about, for example, opioid overdose, we're really now talking about polydrug overdose, because at least 40% of these overdoses involve more than one drug, and estimates range as high as 70%. And of course, for every drug overdose that results in death, there are other factors and impacts not only on the person, but also on society. Surprisingly, there's really only one available option to treat overdose, and that's naloxone, which was approved now quite a long time ago. And unfortunately, its efficacy is limited really to opioid overdose. If the overdose is mainly due to something else, it's not going to be as effective. And a practical problem is that agitated patients, agitated because they're going through acute withdrawal due to the naloxone, consume significant emergency room resources. And also, in the time of COVID again, the response personnel are a little extra cautious about that, how they need to handle these patients. Naloxone can definitely save lives, but naloxone and other opioid receptor antagonists reverse all opioid actions. So in the hospital setting, they unfortunately also block the purpose of giving the opioid, and that is for pain relief. In the community setting, as mentioned, they precipitate withdrawal, which is a problem in and of itself for the healthcare providers, but it also really impedes the inclination of the patient to want to seek treatment for their substance abuse in that acute withdrawal setting. So for these reasons and more, Dr. Cotton in 2014 suggested that what we really need is a generalized ventilatory stimulant, and it should be agnostic to the cause. In other words, independent of the chemical cause of the respiratory depression. It should not block opioid receptor mediated pain relief, and it should not precipitate withdrawal, which leads to the problem of combativeness and others for the caregivers. So that was a call to action. How do we get there? Well, let's step back. How would the body address respiratory depression? Well, control of respiration, we think immediately of the central nervous system, and in particular the brain stem, and indeed specific nuclei within the brain stem. So the parabrachial nucleus and the Brie-Botzinger complex. And in particular, the Brie-Botzinger complex represents an interesting target because it contains the cells that initiate spontaneous breathing. It is the main location of rhythmic pattern generation that's involved in breathing. And importantly, it's the site, or one of the main sites of opioid-induced respiratory depression. So it makes a logical target. And indeed, the central nervous system has been the target for many, many decades, if not longer, for stimulating respiration. One of the newer approaches are the ampakines. The ampakines are sort of a class of chemical substances. They're benzamide and related structures that have the added property that they allosterically modulate the AMPA subtype glutamate receptors, hence the name, where in the brainstem Brie-Botzinger complex. So here's an example of targeting that central activity. Now there have been a few compounds, one of which was CX717. It mitigated alfentanil-induced decrease in ventilatory frequency, but there was a very, very large variability in effect. And unfortunately, it had relatively poor oral bioavailability and blood-brain barrier penetration. Remember again, this was the site of action. And it had a slow onset. This was followed up by CX1739 to try to overcome some of these problems. It rapidly crosses the blood-brain barrier, and at least in rats, it reversed the respiratory depression induced by an opioid, pentobarbital, and ethanol. So it begins to approach the idea of an agnostic agent. Again, it's targeting the central nervous system, so as one might expect, there are central nervous system adverse effects, and the development of this and these compounds is yet to be determined. Now, another approach evolves from the idea of control system. Clearly in the body, the respiratory system is designed as a control system, meaning simply there's feedback control, just like almost every other system in the body. So the easiest way of thinking about this is what we do every time we take a shower. We use our hand or whatever to determine the concentration, and we use that as a feedback loop to increase or decrease the amount of hot water or cold water that's coming in there, and therefore we can adjust it to the desired temperature. We do the same thing by having input to the control of temperature in a room by adjusting the thermostat. So we are no longer the sensor, but we set the thermostat. It monitors the sensor, and it puts greater emphasis on the heater or cooler to control the room temperature. In the case of the respiratory system, we have as the initiator, as mentioned, the brainstem respiratory centers. This sends input to the breathing muscles, the alveolar ventilation rate, and the sensors are for the blood pH, carbon dioxide, and oxygen levels in the blood. And this is done by chemoreceptors. And this then feeds back the information to the brainstem respiratory centers. And as you can see here on the right, as oxygen levels begin to decrease, the chemoreceptors pick it up and ventilation rate goes up rather dramatically. And in the combined presence of an increased CO2, which occurs in respiratory depression, the increase is even more dramatic. So where are these chemoreceptors located that are detecting these changes in the bloodstream? Well, a lot of them are located in the carotid bodies. So in both carotid bodies on both sides, right where they can monitor the bloodstream levels of oxygen, carbon dioxide, and the changes that those changes induce on hydrogen ions and therefore the pH. And so they detect the signal and then they send the information to those brain stem nuclei, which are responsible, as we mentioned, for the generation of respiration. So there's a nice feedback loop which involves peripheral chemoreceptors located in the carotid bodies. So this is rather interesting because this might represent a non-central target for influencing respiration and reversing respiratory depression. Now, if we look closer in the carotid bodies, what actually is responding to these changes that occur in respiratory depression, and they are a series of potassium channels of different types. The potassium channels are located on the cell membranes of specific regions in the carotid body, and they modulate the flux of potassium ions, therefore contributing to either the hypo or hyperpolarization of neurons and therefore the responsiveness. Those changes influence the action potential, and that information, which is inherent in the rate of the action potential, is then sent to the brainstem nuclei, thereby completing the feedback loop. Now, if we delve a little deeper, there are particular types of potassium channels that are important here. One is a group called the task potassium channels, and there are several. The ones most important in the carotid bodies for this purpose are task 1 and task 3. When there is a decrease of oxygen or increase in CO2 or change in pH in the bloodstream, this is detected by the task 1 and 3 potassium channels, and that results in depolarization of excitatory afferents, which lead to the brainstem respiratory centers, and that leads to an increased stimulus for breathing. Now again, there's a feedback loop. When these changes occur, signaling respiratory depression, it also influences BK channels, or big potassium channels for short. And when this occurs, there is a negative influence. This is the feedback loop. And this acts as a sort of brake on the system. And again, the feedback loop. Now, these represent interesting targets, peripheral targets, which should have less CNS adverse effects. And two drugs have been developed, doxapram and almotrine, and what they do is essentially stimulate the same pathway that decreased oxygen and increased CO2 do. And so there's already a physiological drive, and this drives it even more to try to get an increase in respiratory depression. So how does that work out? Well, doxapram's adverse effects are limiting, and we have a couple of CNS-related adverse effects. We have dyspnea and hypertension. And albuterol was not approved in the U.S., and it was removed from the EU because of adverse effects, including peripheral neuropathy. So thinking about how they work in this mechanism, they really are doing the same thing as the body is already doing, and the body is already, in the extreme situation, screaming that something needs to be done. So the drugs, doxapram and albuterol, need to really magnify the ongoing effect. So this is how they work in detail, but the point is it's the same thing, the same signaling that the body's doing, but in my lay terminology, they have to scream at the cells in order to be heard over the already emergency signal that the cell is receiving. And therefore, I think it's not surprising that you get these side effects. Now, some researchers a couple of years ago determined that the problem with the adverse effects of albuterol in particular had to do with these areas of the molecule in green, and they eliminated those. And they came up with GAL-021. It's now called ENA-001. And what does that do? Well, that has a totally different target. It targets the BK cell, the big potassium cells. And really what it does is releases the brake. So it decreases the feedback inhibition, and you still have the strong signal, and therefore you allow an enhanced activity, but you can do it with a much lower dose and hopefully a lot less adverse effects. So how does that look? Well, ENA-001 has been called an agnostic respiratory stimulant because it reverses respiratory depression, at least in animals, caused by opioids. Two different ones, benzodiazepines and anesthetic agents such as isoflurane or propofol. And Dr. De Haan in the Netherlands has shown that it also reverses respiratory depression caused by opioids. So in summary then, we have problems with respiratory depression. One is an obvious one everybody's aware of in a community setting, and that's the overdose deaths. The other is a little less well known, and that's the respiratory depression that occurs in hospital settings during post-operative settings. And I think these numbers are underestimated, I think mainly because there's nothing really to be done about them. And the problem is growing. It's growing in the community setting. Rates are at historical highs. And also in the hospital setting, again, because of more surgeries and more at-risk patients. There's also emerging problems. Higher potency opioids, not only fentanyl, but sufentanil, alfentanil, carfentanil, and also polysubstance use, which now may be the majority of cases, and the synergistic respiratory depression that results. There are limitations of current approaches. In the community, the person is put into acute withdrawal. That ends up being a problem not only for them, but also for the emergency folks, and also in a hospital setting because it reverses the pain relief that's the purpose of giving the opioids. So some folks have called for an alternate strategy, say what's needed is something that will stimulate respiration independent of, or that is agnostic to, the chemical cause. And there are some ideas being tried, and hopefully there'll be clinical trials in the not too distant future, and even more hopefully there'll be a benefit to those patients who need it. So with that, I thank you very much.
Thank you very much, Dr. Rafa, for this registered lecture. we'll have the possibility at the end to discuss it, and we'll go directly to the next lecture of Dr. Frank Breathe, the use of ketamine for opioid use disorder.
Okay, good morning, everybody. I am very happy to be here. I have nothing to disclose for preparing this presentation. Well, actually, I do have one disclosure to make, and that is that I'm very happy to be in Roma to do this presentation. Extremely fortunate. And I'd like to thank Dr. Justina Barassi for inviting me to speak in the land of my ancestors. So, ketamine. To begin, I think ketamine is a misunderstood drug. On the one hand, it is a drug used in anesthesia and known for causing amnestic and dissociative effects. It carries the stigma of being an abused and addicted drug. On the other hand, when used in proper doses, it can be highly effective for treating various pain conditions, depression, possibly addiction, among other conditions. So, a few slides about opioid use disorder. It's an enormous problem plaguing all of society, as I'm sure you're well aware of. It's becoming more prevalent. In America, more than 92,000 people died from drug overdoses last year. This was a 30% increase from the prior year. The last couple of decades saw an increase of 22 times more fentanyl deaths and an increase of 7 times more heroin deaths. Over the last few years, emergency room visits for opioid overdoses increased by 30%. 4 years ago, the opioid epidemic was declared a public health emergency in the United States. So what is the connection between COVID-19 and opioid use disorder? Well, it's obvious that COVID has been a complicating factor in overdose deaths. As COVID cases increase, the number of OUD cases increase. A recent study calculated that hospital patients who had an OUD diagnosis as of September 2020 were over 10 times more likely to have COVID than those without. So what we have is an epidemic of opioid use disorder within a pandemic of COVID. Now, we must realize that opioid use disorder is a global phenomenon. Approximately 275 million people worldwide took an illicit substance at least once in 2019. These statistics are from the United Nations Office on Drugs and Crime, and they are very sobering. Among those, 62 million people used opioids. This is worldwide. There were 500,000 deaths annually from drug use. More than 70% of these were related to opioids and more than 30% from overdose. About 36 million people worldwide have a drug use disorder. And the harsh reality is that opioid use disorder can be treated, but less than 10% of people who need treatment actually receive it. I was listening to one of the programs on the news the other night, and the British Broadcasting Company mentioned that failure to provide the world population full access to COVID vaccine, and because of all the pandemic restrictions, this is going to result in a $9 trillion loss to the world economy. So this is very sobering, and this will undoubtedly increase opioid use disorder cases. So we need to expand access and develop new treatments. I'm having trouble advancing this. So there's only 3 approved treatments for opioid use disorder. Your methadone, the full opioid agonist, the buprenorphine, the partial opioid agonist, and the naltrexone extended release, the opioid antagonist. These are all safe and effective in combination with counseling and psychosocial support, but there are issues with these agents. And there is a need for more drugs. I mean, methadone was the first one that came out back in 1947. It was approved for analgesia and antitussive uses, and then they found that it was effective for treating opioid addiction. They finally approved it in 1972 for that purpose. In 2002, the buprenorphine and combinations were approved, and the most recent entry is the naltrexone in 2010. But we need more. We need more treatments. So what recently has been happening is there's been research going on with ketamine, because it is a novel approach to treating OUD. Now, what ketamine is, it's a racemic mixture, 50-50, of right and left stereoisomers. The molecule is pictured there. The amine in ketamine is from the amine moiety on the ring structure in the molecule. The nice feature about this drug is it's rapidly metabolized and distributed. There's multiple routes of administration. It can be given IV, IM, sub-Q, inhalation, oral, sublingual. So it acts on the NMDA receptor, which is important for controlling synaptic plasticity and memory function, and is thought to work for opioid use disorder by rewiring neural networks responsible for addictive tendencies. And the research hasn't stopped with opioid use disorder. They're currently looking at ketamine for alcohol and cocaine addiction, for acute and chronic pain, for headache, for anxiety. It's been found to be very effective for treatment-resistant depression, both unipolar and bipolar. Post-traumatic stress disorder, it's been very effective. Obsessive-compulsive disorder, fibromyalgia. So there's an evolving list of indications, potential indications that can be approved for ketamine. So the right side of the molecule can both alleviate withdrawal symptoms and produce effects that help sustain abstinence. And the left side of the molecule is known as esketamine, and it works more effectively as an antidepressant. A little about the history of ketamine. It actually was developed as a replacement for PCP. PCP has been around a long time. That was developed in 1926. It was marketed as an anesthetic medication in the 50s, but because of the side effects, the use was disallowed in 1965. It was still used in the veterinary medicine, but that was banned in 1978. So ketamine is the replacement for that. It was synthesized in 1962. It was approved in 1970 for anesthesia and sedation in the OR. Some of the stigma attached to it came about in the 1980s, when it was a popular club drug. It was known as Special K, Cat Valium, and this was abused. People wanted to get high. They wanted the out-of-body experience. They wanted the LSD-like hallucinations, and this is an unfortunate aspect of this, and this is why there's a stigma attached with this drug. Now, ketamine is inexpensive, and it's widely used in developing countries. It's on the World Health Organization's essential drug list. The DEA classified it as a Schedule III controlled substance in 1999, and most recently, the approved product, the left side of the molecule, for esketamine nasal spray for treating severe depression, very effective. In 2019, we came out with Spravato. I'm sure you've heard of that. So this is the pharmacokinetic profile. You can see that it crosses the blood-brain barrier, binds to receptors in the prefrontal cortex, which is responsible for learning and memory, which is very important for how this drug works for OUD. The onset of action is rapid. The duration is short. The half-life is relatively short. There's hepatic metabolism, urinary excretion. The main metabolite is norketamine, which is 1/3 as potent as the parent drug. This is the NMDA receptor, and So basically, it's a glutamate receptor and ion channel found in neurons and present throughout the central nervous system. Ketamine is a non-selective NMDA receptor antagonist, and it has equal affinity for all the different receptor subtypes. So it works by allowing sodium and calcium to flow into the cell and potassium to flow out of the cell. What this does is mediates neuronal signaling for pain, neuronal plasticity, and central sensitization. The NMDA receptor antagonist can reduce neuropathic pain and spontaneous pain. So this essentially is known as a dirty drug. It doesn't just target one system in the brain, but dozens of systems. Ketamine affects the glutamate system, which allows neurons in the brain to communicate. At high doses, ketamine seems to block glutamate, making it an effective anesthetic. But at low doses, ketamine production is enhanced. This can have a variety of effects. Some individuals hallucinate, or they feel they're losing touch with reality, the so-called out-of-body experience. But it may also help build new connections or synapses between neurons. When people are under stress for a long time or depressed for a long time, they can start to lose the connections. When ketamine is administered, some of these effects seem to begin to reverse. It is believed that ketamine may help regenerate neuronal connections, which is the basis for the remapping of addiction pathways. This is a nice schematic of the NMDA receptor. So these are ligate-gated channels activated by the excitatory neurotransmitter glutamate. Glycine is a co-activator. So this creates a non-selective channel, highly permeable to both calcium and sodium. It's very important for controlling synaptic plasticity and mediating learning and memory functions. The receptor is inotropic and allows for passage of calcium and sodium into the cell and potassium out of the cell. This is what mediates the effects. Magnesium ions prevent excessive activation, and zinc ions directly inhibit NMDA-sensitive glutamate-gated channels that seem to have a role in treating depression. In terms of mechanism of action, this is a really nice schematic. It shows a wide range of cellular processes at concentrations within the clinical dose range. You can see that this is quite extensive in terms of all the different areas that ketamine acts on. The rapid effects and actions are represented at the top left, and the more delayed, prolonged effects and actions are represented towards the bottom right. The precise mechanism of action remains mysterious for ketamine. Hypnotic effects appear to be largely mediated by blockade of NMDA and the histamine receptors. But there's cholinergic, aminergic, and opioid systems appear to play both a positive and negative modulatory role in both sedation and analgesia. The opioid component is much less. It's not so much the parent drug that affects that, but more the metabolite, which is not as potent as the parent drug. So ketamine effects in chronic pain and as an antidepressant far outlast the actual drug levels and are probably mediated by a secondary increase to structural synaptic connectivity that is mediated by a neuronal response to ketamine-induced hyperglutaminergic state. This is the physiologic profile, the various systems that ketamine affects. In the CNS, we can see it prevents central sensitization by interfering with transmission in the spinal cord. In the heart, it inhibits reuptake of catecholamines at nerve terminals. It increases heart rate, blood pressure, and cardiac output. So these parameters need to be monitored when ketamine is being administered. In the lungs, it stimulates the B2 adrenergic receptors, relaxes bronchial smooth muscles, bronchodilation, increases salivary and tracheal bronchial secretions, especially in children. Ketamine is used routinely in kids to help calm them down, to relieve pain. But the key thing with the effects on the lungs is that it does not promote respiratory depression. unlike the approved agents for opioid use disorder that act on the opioid receptor. So this is the one distinguishing feature. In the brain, it increases cerebral blood flow, cerebral metabolism, and intracranial pressure, but it doesn't change the seizure threshold. Now, the sensory effects are well known. The hallucinations, the out-of-body experiences, so this can occur, vivid dreams, and there can be emergent reactions when the drug wears off. Now, perioperative use, I'll just go over this quickly. Ketamine is widely used in the perioperative setting for pain and analgesia, and it reduces the opioid burden, often with extended effects. A single infusion of ketamine has been reported to reduce development of chronic pain in the first 180 days after surgery. So the effects are long-lasting. So ketamine and pain syndromes, there's a lot going on here. It's widely used to manage acute and chronic pain. I've been seeing it increasingly used in the critical care setting. ER physicians routinely administer ketamine bolus doses for pain and sedation, and with very good results, at least I'm told. So this is great for acute pain, chronic pain. It reduces peripheral sensitization, reduces central sensitization, and also it reduces the opioid-induced hyperalgesia effect, which can be a problem with the conventional opiates. So ketamine effects on pain. So there are multiple things going on here with the different receptors that come into play. It does act on opioid receptors in a weak fashion, nicotinic, muscarinic receptors. Ketamine may facilitate endogenous pain pathways in some circumstances, and the anti-inflammatory qualities of ketamine may contribute to its efficacy for pain relief through a reduced microglial activation and reduced cytokines, tumor necrosis factor, and interleukin-6. There's prolonged pain relief for some chronic neuropathic pain syndromes after drug levels are reduced, which suggests downstream mechanisms. The antidepressant effect endures after a drug has been eliminated and may be related to prolonged analgesia. Now, it's important to note that ketamine's analgesia differs from the opioid analgesia, because we know this naloxone does not reduce ketamine effects. So I'm told that this has been, the infusions for pain have been going on for quite some time in Europe, that there are ketamine infusion stations that are available for decades. Most recently in the United States, they just started coming out with these psychedelic clinics. The psychedelic clinics, they're popping up all over the place. These clinics attempt to treat numerous psychiatric conditions. They purposely induce an out-of-body experience with the goal of decreasing inner tension and causing a positive change of emotional attitudes. So people are going to these clinics, and they're getting high, and they're going there with the intent of getting, reduction in some of their mental issues. Now, I don't know, the jury's still on this. I don't know if this is for legitimate purposes or if it's just a guise for illicit use. But there always is a danger of a ketamine epidemic if this drug is being used widely for recreational purposes. But I think we're past that. I think that happened back in the 80s. So now the issue here is looking at just a few of the positive effects that have already been determined with ketamine. Post-traumatic stress disorder works very well for this. It reduces symptoms faster than midazolam, reduces comorbid depression, is well tolerated, and does not have persistent dissociative symptoms. There are a few effective pharmacotherapies for PTSD, and the non-responder rate is very high. Clinicians often prescribe benzodiazepines, but they're really not indicated and they don't work too well. So what we're here for is to see what the connection is with ketamine and opioid use connection. Is it an effective treatment? So far, some of the studies for ketamine have shown increased abstinence rates, reduced withdrawal symptoms, reduced craving, which is very important, and better rehabilitation outcomes. You have to use psychotherapy in conjunction with these treatments. And it seems that the psychotherapy works better because patients accept the psychotherapy better when they're under the influence of ketamine. Results have been variable. There's more research that's needed. There's not much research out there. Now, I am putting together a few studies that I was able to come up with that mentions, what happened when we're using ketamine for opioid use disorder. This one study, there are two of them actually, the Krupinski study, 70 heroin addicts were randomized to high dose or low dose ketamine plus psychotherapy. Abstinence rates at 1 month were 85% in the high dose group and 55% in the low dose group. And heroin craving was lower in the high dose group. The second study looked at heroin addicts that were randomized to 1 or 3 sessions of 2 milligram per kilogram IM ketamine a month. And 50% of those in the 3-session group were abstinent at 1 year, compared to 22% of the 1-session group. The 3-session group had significantly less heroin craving than the 1-session group. Now, the thing with these studies, there are study limitations. Studies have to be designed very well to really derive the full benefits of how ketamine can impact opioid use disorder. With these two studies, some of the limitations were there was no placebo group, there were only low-dose comparison group, there was no follow-up on the opioid substitution pharmacotherapy, and subsequent opioid antagonist use in the follow-up phase was not assessed. And the abstinence rates were not tracked in interim follow-up. So this limited the discernment of duration of effects. So this is a problematic issue in the study design. So with better designed studies, we may see better benefits. Now there was another study. This was the Jovasia et al. Study. This looked at opioid-dependent patients randomized to opioid antagonist induction or placebo or sub-anesthetic ketamine infusion. They did this at a 0.5 milligram per kilo hour infusion. 50 patients were in the study. Ketamine patients had better control of withdrawal symptoms, and this lasted well after the drug infusion. There were no differences in outcomes among the 4 groups at 4 months. This study found that sub-anesthetic infusion of ketamine was effective to reduce the opioid withdrawal symptoms, but the single infusion did not have long-term effects. So some study limitations here was that subsequent opioid antagonist use in the follow-up phase was not assessed, and abstinence rates were not tracked in the interim follow-up, limiting the discernment of duration of effects. So these are issues in the study design, and the more studies are needed. I did come across a case study that was very compelling, this LaLaney case study. This is a 36-year-old woman with low back pain and mental health disorders. She had a histrionic personality disorder with borderline traits. She developed dependence on opioid analgesics. She was taking huge doses of opioids. She wanted to stop taking the opioids. She was admitted to a psychiatric hospital for detox. They used a formulation of ketamine oral solution, a 5 milligram per ml concentration. They infused her at a milligram per kilogram, or they gave it orally at a milligram per kilogram, and they started reducing her opioids by 10% every 2 days. There were no withdrawal symptoms, and she was discharged from the hospital after several weeks, but she's still in outpatient psychiatric care. She now receives codeine 50 milligrams 3 times a day under supervision by the home nurse visit. Now, so I went back and I looked at this study. This is what this lady was taking before the ketamine intervention occurred. She was taking OxyContin 20 milligrams twice a day, oxycodone 10 milligrams every 4 hours, and acetaminophen codeine 325 6 times a day. Huge amount of opiates. I calculated the morphine milligram equivalent, and it came out to 172.5. And now that she's on the low dose opioid, the codeine, she's getting codeine 50 TID. The MME equivalent there is 22.5. So they went from 172 to 22. It's amazing results. Finally, there's one other study that I want to mention, and this was through the VA, the Veterans Administration, a Malcho study. Without going into all this detail in here, this study provides new evidence that the utilization of a standardized ketamine protocol coupled with a rapid opioid detox is very effective, results in a high rate of prolonged opioid cessation, decreases chronic pain, and minimizes opioid withdrawal using strictly non-opioid analgesics. So these studies, I mean, to me, they show that this is a huge area for research, and it's very compelling, and it's just a matter of finding the right dose, the right interval, and doing the proper monitoring. And I think that this drug being used in a controlled environment can be very effective for opioid use disorder. Now, there are some barriers. Of course, there's always barriers, and these are some of them. It's a novel therapy. There's little experience with it. Physicians don't know how to use ketamine for opioid use disorder. The stereotypes are out there about, use as an analgesic, as a dissociative, with the dissociative effects. Risk of ketamine addiction, which really is not a consideration if this is being used clinically and being monitored with clinical doses as opposed to recreational doses. It really wouldn't be a consideration. But addiction specialists may have other preferences. They may be quite happy with using methadone or buprenorphine, so I don't even want to mess with ketamine. Also, there can be administrative issues. I mean, the facility or the practitioner would have to establish a ketamine program. What are the costs? What's the return on investment? There has to be a policy and procedure development for adherence and compliance. You have to make sure that you do this. I mean, if we did this in the States, we're scrutinized by the DEA over any controlled substance. They will come in and they'll look at everything. They'll look at your record keeping. They'll check they'll reconcile your records, and they'll do audits. And if they find one discrepancy, they'll cite you and fine you. So that's a big problem to overcome. So logistics, of course, how will the ketamine be prepared if you want to go this route? Will it be extemporaneously compounded? Are you going to farm it out and have another site prepare it for you and bring it in? What are the manpower considerations? So these are all things to be considered. Finally, I just want to conclude with saying that I'm having trouble with this. Ketamine seems to be very promising, in my opinion, a very promising new treatment for opioid use disorder. The study showed that it may increase abstinence rates. It may work for reducing withdrawal and reducing cravings, and it makes behavioral therapy more effective, the psychotherapy that's used in conjunction with the treatments. The unique mechanism of action on the NMDA receptor as opposed to the opioid receptor, I think is a big advancement. All the studies demonstrated efficacy, safety, and tolerability, and there's favorable costs, may be a benefit for utilization. Ketamine's been around for over 60 years. It's a cheap drug. It's probably on a par with methadone. Methadone's very cheap, but a lot cheaper than buprenorphine or naltrexone, trust me. But more research is needed to elucidate its role and gain wider acceptance, and greater physician awareness is needed. Greater physician awareness and education to overcome the stigma of ketamine being unsafe and addictive. Physicians need to understand that ketamine treatment levels are safe and effective, whereas ketamine abuse levels are not. And I'd like to leave you with a quote by Marie-Paul Keeney, world-renowned French virologist and vaccine expert, and a former Assistant Director General of Health Systems and Innovation at World Health Organization. And this is what she said, quote, "The medical benefits of ketamine far outweigh potential harm from recreational use." So I leave that for you to draw your own conclusions. And that is the end of my presentation. I have questions, and grazie. Thank you.
Thank you very much, Dr. Brave, for this presentation. We are a little bit over time, and I don't know how much time we have for the conclusion of this session. Anyway, I would like to thank all the speakers for their interesting lectures, the present lectures and the registered lectures. And I couldn't see any question in the list of the meeting. I think that we have to bear in mind not only the risk of opioid crisis, but also the possibility if we have also this crisis also in Europe as it is in the United States. We don't have the time to discuss it now, but it's important for me to leave the message to the people who are listening to us that there are possibilities. First of all, opioids are important to use in pain treatment. We don't have to forget it. And we have also the possibility to decrease mortality with the use of opioids in pain patients. And only to remind you, the warning signs in opioid-dependent patients are very important. The doctor that is treating the patient should look at these signs and decide immediately whether to go on with this treatment or not. And then there are some important rules that we have to accept if we want to continue use opioids, and we have to use it. And I think this is an area of another meeting and another lecture. And I will suggest to finish this section now and to thank Professor Varassi for organizing this great meeting. It's not easy to organize a meeting and a hybrid meeting in this time of COVID-19 pandemic. And he did it as he did it before, many years ago, before the pandemic. And he will go on doing it, inviting excellent speakers for this lecture. And I want to thank also Professor Narvaez from Bolivia, my co-chairman. And I hope we can go now to the next meeting. Thank you very much.
So I think we can start with the last session of this very interesting Congress. I want to thank the organizing committee for giving us the opportunity to host this industry-sponsored session. And this is the last session of the Congress, and the topic is chronic neuropathic pain and immune system. So this is a particularly relevant topic. I'm Marcello Allegretti, I'm Chief Scientific Officer at Dompé Farmaceutici. We have a historical interest in the pain area, and we are actively involved in this phase of our research life in the identification of potential new targets for the treatment of neuropathic pain. So this topic is particularly relevant because we are all perfectly aware of the fact that immune cells are not passive bystanders at the nervous system. So the interest in understanding the role of immune cells in the development, maintenance, and propagation of neuropathic pain is key for the identification of novel pharmaceutical approaches. And this comes from preclinical research studies that are giving a tremendous contribution in the understanding of the physiopathological mechanisms, identification of novel targets, but also from clinical research, where imaging studies are clarifying and confirming the glial activation in the context of neuropathic pain. So I hope that this session will be helpful for us in understanding the status of the research in the field and in guiding us in better understanding which are the implications from the pharmacological perspective of these findings. I'm particularly glad to have in the speakers panel clinical researcher, preclinical researcher, basic science, because I strongly believe that only the continuous dialogue between clinical, preclinical research will support us in transforming the knowledge in pharmacological treatment for patients. Our first speaker is a very important clinical researcher, Professor Caterina Aurelio. She's full professor at the Second University of Naples. She is also director of the anesthesiological and surgical science department and emergency in the same university. She covered very important roles in Italy in the pain area. She is past president of the National Association for Pain Studies. She is responsible for the pain area in the CRT, very important Italian association. But she's also actively involved in the clinical research. So she's author of many publications in which she covered the neuropathic pain research, both from the pharmacological point of view and clinical perspective, but also with a particular attention in the drug-related mechanisms that are key information for the design of novel therapies. So today she will give us a presentation on new transmitter responses to drugs acting on the CNS, and we are very eager to hear.
Thank you for the presentation. I would first to thank Procacci Foundation for inviting me to this great Congress. And now I have the pleasure to share the presentation on transmitter response to drugs acting on the central nervous system. I have no conflict of interest to declare. The amino acid drugs, the gabapentin and the pregabalin, are mainstay treatments for neuropathic pain from diabetic neuropathy, postherpetic neuralgia, or spinal cord injury. In this table are reported the last guideline on neuropathic pain, where the gabapentinoids are rating to level A for efficacy and are recommended for the first line of treatment in patients with neuropathic pain. A protein first identified as an auxiliary submit voltage gate, the calcium channel, the alpha-2 delta-1, is the high affinity binding site for gabapentin and pregabalin and is required for the efficacy of these drugs. The alpha-2 delta-1 submit protein binds directly to the calcium channel per protein. This modifies both the kinetic and the localization of calcium channels. In this table, are reported the protein that directly act with the alpha-2 delta-1 and are CAV1 and CAV2 of calcium channels. The CAV1 of skeletal muscle of calcium channel, the subunit of NMDA, NR1 and NR22, neuroxin 1 alpha, and thrombospondin. The effects, the alpha-2 delta-1 act directly, increasing the stability and the kinetics of calcium channels, promote the release of NMDA presynaptic current, and promote the formation of new synapses. This is the alpha-2 delta-1 representation that is based on cryo-electronic microscopy and molecular modeling of calcium channels. The alpha-2 delta-1 in green include von Willebrand A that modulate the interacting with alpha-2 delta-1 and the calcium channels, and include also CAH1 and CAH2 in brown and purple that are the pore of the functioning of alpha-2 delta-1. Most investigators conclude that gabapentinoid analgesia derive from reducing the excitability of neuron networks by reducing the numbers of functional calcium channels. But recent research show that gabapentin and pregabalin act by modestly reducing the membrane localization and activation of voltage-gated calcium channels at synaptic ends in spinal cord and neocortex via binding to the alpha-2 delta-1 protein. However, the molecular details of reduced transmitter release caused by gabapentinoids have not been clear. Recent studies show that alpha-2 delta-1 alters the function of proteins other than voltage-gated calcium channels. In particular, act on certain receptors of NMDA and specifically modify some actions of neuroxin 1-alpha and limit some actions of thrombospondin. Here we can see how gabapentin refers to neuroxin and at synapses diminish the size of presynaptically vesicle, and gabapentinoids interact also with thrombospondin from astrocyte and act on the release of vesicle presynaptica and postsynaptica on the spine enlargement. NMDA receptor consists of a tetramer of both NR1 and NR2 subunits, and they are located presynaptically and postsynaptically in spinal cord and the brain. Magnesium block the function of NMDA receptors, and the effect of come vado indietro? And 1 minute, please. And the effect of alpha-2 delta-1 on magnesium block is completely absent in the presence of gabapentinoids. This result suggests that association of NMDA receptors with alpha-2 delta-1 would cause an augmentation of NMDA receptor response, and this would be reduced by gabapentinoid drugs. NMDA antagonists acting at all NMDA receptors have pharmacological profile very different from gabapentinoids. And among these, there are well-known ketamine, that is the most popular NMDA antagonists, but also memantine and diazoxypin, well-known as MK801. These are all far from ideal analgesic or anxiolytic drugs, because they have many side effects consisting in memory disruption, confusion, agitation, nausea, and dissociative effects. This contrasts with gabapentin and pregabalin, which do not cause dissociative effect or psychosis in clinical use. There is a solid evidence of an interaction between alpha-2 delta-1 drugs and NMDA receptor function, but it appears that this inhibition is restricted to only few brain locations at a molecular subset of NMDA receptor. This condition needs more research on this argument. It has been known for however, it has been known for 20 years that spinal alpha-2 delta-1 is markedly upregulated after peripheral nerve injury, and that this upregulation causes neuropathic pain symptoms. The increased NMDA receptor response are blocked by acute application of gabapentin and pregabalin. And the subnits proteins of NMDA involved in these conditions are neuroxin 1-alpha, that are an additional target of gabapentinoids. And these are a family of presynaptic proteins that protrude from presynaptic terminals into the extracellular space with diverse function, but principally modulate synapses function. Application of 30 millimole reduce of pregabalin reduce neurotransmitter release by about 50% by synaptic vesicle, and extracellular application of a soluble fragment of Neurix 1-alpha reduce neurotransmitter release to this same extent of pregabalin and occluded the effects of pregabalin, suggesting that pregabalin and neuroxin works at synaptic function through the same molecular pathway. Thrombospondins are other proteins of subunits NMDA receptor, and also these are an additional target of gabapentinoids. These are a family of extracellular matrix protein that in the brain are formed mostly by astrocyte, and we well know that astrocyte play a major role in pathogenesis of chronic pain. After neuropathic sensory nerve injury, thrombospondin induces chronic pain and increases the number of excitatory synapses. And gabapentin and pregabalin inhibit several thrombospondin effects via alpha-2 delta-1 and prevent the formation of new synapses in response to thrombospondin application or astrocyte activation. Repeated treatment with gabapentinoids reduce the formation of new synapses induced by thrombospondin and pain-related behaviors. In response to neural damage, the astrocyte activation and the subsequent release of thrombospondin with the new glutamate synapses may be prevented by gabapentinoid drugs. It seems likely that the interaction between gabapentinoid drugs and the thrombospondin function may be relevant for preventing long-lasting pain-related anatomic changes. It is clear that analgesic effects of gabapentinoids involve an interaction between alpha-2 delta-1 and the voltage-gated calcium channel, but also other proteins. The more studies studied in the recent research are the subset NMDA receptor, neuroxin 1-alpha, and thrombospondin. The interaction of the thrombospondin with alpha-2 delta-1 and gabapentinoids may be important when the pain is augmented by activation of glia that release thrombospondin to form new and enlarged glutamate synapses. It is not yet known whether alpha-2 delta-1 interaction with the thrombospondins and NMDA receptors or neuroxins are mutually exclusive with each other or with the calcium channel alpha-1 proteins. And this is more to study to ameliorate this condition. An important step in this direction was provided by findings that glycerollyl phosphatidyl inositol anchor at the membrane portion of alpha-2 delta-1 is required for increasing cellular calcium currents. In conclusion, existing evidence suggests that alpha-2 delta-1 thrombospondin interaction independent of calcium channels be important for gabapentinoid drugs to reduce long-lasting pain with only acute treatment around the time of nerve injury. And we think that this input may improve new research on the treatment of known and the treatment of neuropathic pain.
Thank you for this interesting presentation and introducing us to a very complex pharmacological question, so the mechanistic aspects of the gabapentinoid treatment. So you introduced us to several protein targets that are crucially involved in the gabapentinoid treatment, but also on the implication on the new interpretation of the potential of gabapentinoid in treatment. So I was wondering if from the mechanistic point of view there is evidence of direct interaction between gabapentinoids and thrombospondin either, or if there is only indirect effect through the alpha-2 beta-1 subunits.
No, in this research that I have read, they have I suppose that they are very interesting because many years ago, my first works was on NMDA receptor and MK-8001. And this is also an open situation for new studies. Gabapentinoids act, the interesting is that gabapentinoids act on alpha-2 delta-1 protein, but modestly, not too much how 20 years ago we think. And this is a new situation, a new condition for researcher to, is an open space for new researcher and to speculate on the NMDA research, NMDA that is there are few works about this canal that is very interesting for the chronic pain and the neuropathic pain specifically.
Thank you. Fully agree on this observation. The next presentation is by Professor Livio Longo. Livio Longo is associate professor at Vanvitelli University of Naples. He earned his PhD in pharmacology in 2008. And since then, he has been working in the field of neuropharmacology, dealing with several aspects, but with a specific focus on neuropathic pain. Interesting since the very beginning, he has dedicated his research to the understanding the mechanistic aspects leading to the identification of potential new targets, and particular focus on cannabinoids, endocannabinoids, and purinergic system in the context of neuropathic pain, but also now involved in the research of inflammatory mediators, chemotactic signals in development of neuropathic pain. He will guide us with a an overview of the research in the field, and so we will listen to the presentation with very high interest.
Thank you, Dr. Allegretti, for this very kind introduction. Probably I don't deserve it. And I would like to thank the organizing committee for this invitation. And of course, the title that has been given to me is The Role of Immune System and the Microglia in Neuropathic Pain. So, of course, you've seen probably yesterday by Tony Dickinson this slides, how complex is neuropathic pain, involving several areas of the spinal cord and also supraspinal area into the brain in both ascending pronoceptive pathway and descending antinociceptive pathway. What happens is actually a lot of synaptic plasticity phenomena, which are basically driven in part by immune system, peripheral immune system and central immune system, which is represented by microglia cells. We got several kinds of neuropathic pain. Of course, I don't have to say to this audience, but actually we can have neuropathic pain come from the periphery and also central neuropathic pain, such as, for example, central post-stroke pain. All of that, they are basically untreated or not really well treated. So what happens is that when you start the treatment of neuropathic pain, beginning you will have some effect, and then this effect is lost during the time. And this is also for the opioids, as you probably know better than me. So despite the neural center point of view of neuropathic pain, of course the neurons are the cells that undergo suffering and then also plasticity, but as I said before, probably this well-being is maintained by other cells. So we have to imagine brain as a kind of orchestra, so all the components of the orchestra should work in a right way, otherwise we lost the synchrony. So very important role is played by astrocytes, and in particular in the last years, microglia role has merged. Microglia cells are quite young cells, have been discovered 100 years ago by Pio de Rio-Ortega. Through simple technique, the Golgi staining, he highlighted several shapes of these cells, several morphology of these cells. So now we are lucky because we know that all these different shapes of the microglia are also associated with different functions of the cells. So usually microglia is called resting condition, is a macrophages of the brain, okay? It does not derive from the bone marrow, but derived from the yolk sac, and then after the closure of neural tube, microglia become entrapped into the brain parenchyma and acquire specific shape of the neural cells. So, as you can see here, usually it's like that. Very long processes and small cell somata, but these processes are continuously moving, patrolling to the brain to see whether or not the synapses are in a well state or has to be removed, for example. This happens, for example, in brain development and then also in Alzheimer's disease. So when we have, for example, for the neuropathic pain, a massive release of substances into the dorsal horn of spinal cord, imagine, sciatic nerve lesion, microglia change phenotype and change morphology, as you can see by this video over here, by retracting processes and increasing the small cell somata. And in this case, microglia become as a micropump, able to release several substances, such as pro-inflammatory or anti-inflammatory cytokines, depending on the microenvironment. Also, if we have, for example, an infection into the brain or into the central nervous system, microglia suddenly migrate to the side of lesion or infection and start to phagocytate, the debris that are formed. This happens not only when there is an infection, this happens also when during pathological processes where, we have a big amount of debris which is, deposited into the brain. These cells have been, they have a kind of dichotomy because, in 2004, microglia were considered the bad guys. So the dark side of the glia, coming from the Pink Floyd album. But in 2010, Manuel Graber, highlighted the changing face of microglia. So we also know that the microglial cells are protective for the brain. So if they do not work, actually, the debris into the brain are not removed, okay? So we have a lot of rubbish into the brain. Indeed, the complexity of the phenotype of microglia that at the beginning were actually two, erroneously called M1 and M2, okay? So at the beginning was M1 is the pro-inflammatory phenotype of microglia, M2 is the anti-inflammatory phenotype of microglia, where the situation is quite more complex since we have several other phenotypes, as we will see later. What we know is that if you stimulate, for example, P2X4 receptors through ATP, you will have the polarization of microglia toward a pro-inflammatory phenotype. If you, for example, stimulate with cannabinoids or adenosine, you will have an anti-inflammatory phenotype of microglia that do repair. But the situation, as I told you, is quite more complex since we have several other phenotypes, particularly the one of the alternative activated state of microglia that, depending on the antigen surface marker and the cytokines and chemokines that they release, can exert different functions. Particularly, this phenotype over here is quite new, is the dystrophic. As you can see here, there are no markers to highlight this, okay? This has been focused for the research for a long time. Has been highlighted by the group of Jack Straits, in the post-mortem human brain, where he tells us that dystrophic rather than activated microglia are probably in charge with the suffering of the neurons in degenerative disease. We also highlight this in collaboration with a group of Alessandro Usiello some years ago, and we found in mice, transgenic mice, in a model of a hyperglutamatergism, so a lot of glutamate into the brain, these mice were very smart during the young age. And then they start a cognitive decline very early. This was correspondent with the microglia, dystrophic microglia cells that we found. I cannot really see the picture. Okay, here. Dystrophic microglia here and dystrophic microglia here in the KO. This is, when you see the processes that are not linked to the body, actually, we can talk only through morphology of dystrophic microglia, till now, okay? And also this is associated with the different possibility to exert long-term potentiation, so memory and learning. So going back to the pain, actually, what happening to the spinal cord, for example, when we have a lesion of sciatic nerve, is that there is a proliferation and activation of microglia ipsilaterally to the nerve lesion, okay? So as we can see here, this comes from Minzuo lab, our friend in Toronto, and also in the lumbar spinal cord because of the common peroneal and sural part of the nerve that goes into the spinal cord, okay? So interesting, we contributed that in the past when I was in the Marzia Malcangio lab and the Mac Mahon lab, several years ago. And we highlighted the role of microglia in a model, preclinical model of Guillain-Barré, which is induced by, peripheral myelin injection into the tail. So the model is called experimental autoimmune neuritis. And as you can see here, there's a proliferation which was statistically significant in terms of increase in the dorsal horn, but not in the ventral horn of the spinal cord. And this was the first paper highlighting that in mice, in the spinal nerve injury model of neuropathic pain, so the cut of the sciatic nerve, actually we have a very important proliferation of microglia cells into the dorsal horn of the spinal cord. Well, the microglia has to communicate with neurons in chemical way. Okay, they are not really electrically stimulated. So basically what happened is that the neuron has to release something that found the receptors on microglia. Okay, this has been highlighted by Marzia Malcangio some years ago and published on PNAS, and also has been reviewed and also better clarified by my colleague, which is here, Francesca Guida. So what happens when microglia is activated, there is a release of cysteine protease cathepsin S that can cleave a chemokine, which is called fractalkine, into the neural surface. So the soluble form of fractalkine can go to the CX3CR1, which is the receptors of fractalkine, specifically expressed only by microglia into the brain. Okay, so this is a neural microglia crosstalk, and probably is monodirectional in this way. And this, of course, amplified the sensation through the activation, for example, of PP38 MAP kinases. Another important pathway is the P2X4 receptors. I told you before that when you stimulate these receptors, you have pro-inflammatory microglia, okay? The problem is that the P2X4 is upregulated by testosterone. It's testosterone dependent. So this has been highlighted in males, but recently some scientists, in particular the group of Jeffrey Mogin in Montreal, highlighted that in female probably we have other immune cells driving the appearance of the tactile allodynia. So what happens when you stimulate P2X4 is that microglia releases several factors, among them probably brain-derived neurotrophic factor type 1, which is able to downregulate this co-transporter over here, KCC2. So what happened on the neural surface is that when a GABAergic interneuron release GABA on neuron, okay, the chloride remain entrapped in the nociceptive neuron because there is not the co-transporters of chloride. So what happened later, that when you open the GABA-A receptors, which is a rectifier channel, the chloride goes outside of the cells, and there is the action potential, and that's why we have tactile allodynia, this is one of the mechanisms highly debated for the tactile allodynia. As I told you, we have a sex difference in pain. Okay, so in males, probably microglia are more involved than in female. In female, the cells which seems to be a key player in immune-driven tactile allodynia appearance are the T cell. Okay, so T lymphocytes. This is, of course, has been reviewed deeply also by our group in particular. We are basic scientists now. We have to use both male and female mice, okay? Since this paper that came out in Nature 2015 by the group of Canadian scientists. Of course, if we think about the female, if we think about the immune condition, if you think about pregnancy, for example, we can imagine that sometimes pain associated with rheumatoid arthritis disappear. So possibly this is due to conditioning of the TH cells that in some way can, desensitize or sensitize neuronal events. So what I want to convince you is that inflammation and the neuroinflammation are in all the part of the neuropathic pain establishment. So actually starting from the periphery into the skin with mast cell and several other stuff, and then in the dorsal root ganglia where we have, of course, satellite glial cells, and then also into the spinal cord where we have the involvement of microglia through all the pathway that I told you, and then into the maintenance we have an important role of the glial cells, astrocytes and oligodendrocytes. We contribute on that together with a group of Daniela Salvemini recently by knocking down specific receptors on astrocytes, which is the receptors of sphingosine-1 phosphate. Specifically, only in astrocytes, we lost the capability of the S1PR1 modulating drug of, exert anti-allogenic effect. So we have a specific role of astrocytes, especially in the second part, in the late part of the neuropathic pain. And the last few 25 slides, I'm joking, I will a little bit talk about, recent idea of the lifestyle, which is usually has been highlighted for the cardiovascular disease and metabolic disease and so on, also in pain. Okay, this is 2017, if I don't remember, if I'm not wrong, was a SIMPAR, and the lifestyle come also in pain. Why lifestyle come in pain? So we have, our diet, Mediterranean diet, now Mediterranean Asiatic diet, very difficult to do when Professor Varrassi organized the dinner of the conference, very difficult to maintain. But what we know today is that receptors that are involved in metabolism of triglycerides are basically potential target of neuropathic pain, okay? So we have to expand a little bit our view, okay, also to overall common soil between neurological disease, inflammatory disease, metabolic disease. This is a paper conducted by our brilliant postdoc, Serena Boccella, where we highlighted, for the first time, there is only one paper showing that HCR2 receptors, which is hydroxycarboxylic acid receptor type 2, activated by beta-hydroxybutyrate, which is a ketone body produced after prolonged starvation or voluntary exercise, are upregulated in both sciatic nerve and dorsal root ganglia, as we can see here, okay? Also, we have used knockout animals at that time, and thanks to the Max Planck collaboration, very, very important paper that we have done here. So when you inject the mice with the beta-hydroxybutyrate, you can have this beautiful anti-allodinic effect, which is completely lost in mice lacking for these receptors. So these receptors are playing a role in the appearance of allodynia, okay? So what we have done in the past is also to recreate the condition in which beta-hydroxybutyrate can be increased by the liver. So we called Walter Longo, my homonymous, which is quite famous, very more famous than me, that he has done, intermittent fasting diet. So the protocol was almost, I don't remember really well, 36 or 48 hours of starvation. And there was a delay in the appearance of allodynia, which was completely lost in knockout animals. This is the paper. So expand our vision. How we can study microglia in human. Dr. Allegretti at the beginning of the session said we now have some marker for watching glial cells in fMRI, for example. But also we have the possibility to measure specific microvesicles coming from a microglia which are in the liquor, circulating. So we can imagine that when there is a big amount of these microvesicles, we can basically say that there is an immunoinflammatory processes into the brain, as you can see more or less here by this representative image. So to conclude, I will say that the immune system is involved in induction and maintenance of tactile allodynia. The microglia cells, of course, play an important role, especially in the induction of allodynia, and possibly they will lose their capability in the second time to remove the debris from the central nervous system. So we have a problem of suffering of neurons because microglia are not working in a right way. We have sex difference, yeah, probably we knew already knew, and we have to take care our diet. I don't do that, but actually we have to do. Microglia-derived microvesicles could be important for measuring the microglia involvement in human, probably more important for all of you. So I want to thank all of you for the attention, but I have to thank my lab group, particularly my mentor, which is here, Professor Maione. That's why I'm a little bit embarrassed, because, when I talk in front of him, he has been one of the best mentors the person can have. That's why we grew up. And of course, a lot of people around, all the lab group, Serena, Flavia, Carmela, Rosmara, Francesca, I don't have to forget otherwise, And then Vincenzo Di Marzo's lab, Daniela Salvemini lab, Alessandro Usiello, the group of Pierangelo Geppetti, we collaborate with them, the group of Ferdinando Nicoletti, and all of you for your attention. Thank you.
Thank you very much, Livia, for this interesting presentation. We asked you to give us an overview of the research on the role of microglia in this context, and you made perfect job in that. And it's really interesting to see how many hints for pharmacological research come from this rapidly evolving field. So many of the mechanistic aspects you were dealing with are really highlighting potential new targets for the pharmacological management. And I was not aware of your work on the hydroxyl carboxylic receptor 2. That is an old patient in my life, so it's interesting. I was not, I'm intrigued by this, but I want to focus on the potential coming from microvesicles derived, glial-derived microvesicles, because it's really important, and the evolution of technology is allowing us not only to quantify but also to qualify the context of these microvesicles, and this can be a rapidly evolving field. So I want to hear from you how important you feel that the RNA characterization content of microvesicles and other works that are running right now will make this field evolve.
Yes, thank you. This is a very key point, important point, because the contents of microvesicles, also so-called cargo, let's say, is also coming from macrophages sometimes, or from neutrophils, for example, by the way. There are a lot of stuff inside, microRNA, but also a lot of lipids. Sometimes, you can find some endocannabinoids, but also all the, cytokines that can be released. So sometimes also the communication of microglia with cells that are far from there could come from the release of these microvesicles. And you're right, because now we can measure that. Most of the study highlighted the mild cognitive disease, and then they see that when there is this mild cognitive disease, there is an increase of microvesicles, and then part of these patients become Alzheimer-like disease patients. So it's very important to have a kind of, let me pass the words, biomarker for the future, for example, neurodegenerative disease in this kind of stuff.
Yeah, this is an important aspect. So the contents of the vesicles can be relevant biomarkers, but as you highlighted also, they are potential mediators themselves. So it's a very complicated but interesting concept. And I'm sure it will open new avenues. The next presentation is by Vanessa Castelli, a very young researcher with a very rapid scientific career. She has a master's degree in molecular and cellular biotechnology, and she earned her PhD in clinical research and health system in 2020. But despite of the young age and the short career, she has a very brilliant scientific career with more than 50 publication already in her CV, and with several of these publications see Vanessa as the first author and last author on very important journals and international journal, and more in the field of neuropharmacology, and most of her research is dedicated to the cancer-related neuropathic pain and other degenerative CNS disorders. So please, Vanessa.
Thank you for the kind presentation. Good morning, everyone. First of all, I would like to thank the organization and Professor Barrassi. I really appreciate to have the chance to present one of my research here. And I'm going to talk about interleukin-8 at the crossroads of neuropathic pain and neuroinflammation. Chemotherapy-induced neuropathic pain is a common adverse effect and the main dose-limiting toxicity associated with selected chemotherapeutic agents, including paclitaxel and oxaliplatin. Although major efforts are now focusing on preventing the development and on delaying chemotherapy-induced neuropathic symptoms without impacting clinical outcomes, no drugs have yet been approved for the prophylaxis or treatment of these neuropathies. The current therapeutic strategies are based on the continuous modification of the chemotherapeutic regimens to manage the devastating side effects and to improve patient quality of life. Oxaliplatin, a third-generation platinum derivative widely used to treat advanced cancer of colon, causes severe acute and chronic neuropathies, including mechanical disturbances, cold allodynia, and loss of sensitivity. The pathophysiological mechanism of chemotherapy-induced neuropathic pain are not completely understood. However, a large body of evidence correlated the activation of the immune system with the development of chemotherapy-induced neuropathic symptoms. Several preclinical studies indicated that DRG, dorsal root ganglia, and spinal cord astrocytes treated with oxaliplatin and paclitaxel display higher level of pro-inflammatory chemokine and cytokines, including interleukin-8, and decreased level of anti-inflammatory cytokines, leading to neural sensitization and the activation of key pathways involved in microtubule stabilization, axonal arborization, and intraepidermal loss fibers. A recent clinical trial reported a relation between higher level of pro-inflammatory cytokines and the severity of neuropathies occurring upon chemotherapy oxaliplatin treatment in patients affected by colon cancer. However, the exact mechanism linking the increased release of pro-inflammatory cytokine with the development of chemotherapy-induced neuropathic pain needs to be clarified. Consistent with the mentioned evidence, in a previous study, we contributed to clarify the role of paclitaxel-induced interleukin-8 expression as a trigger of neuronal toxicity through the activation of key pathways involved in synaptic plasticity, axonal arborization, and microtubule stabilization, as a trigger of neuropathic pain. Thus, in this study, we investigated the novel selective inhibitor of interleukin-8 receptor, the F2726A, suitable for chronic oral administration, extending the relevance of the activation of the interleukin pathway to the class of platinum chemotherapeutics. As a model of neuropathic pain, we use rats treated intraperitoneally with oxaliplatin or vehicle for 5 consecutive days every week for 3 weeks, as you can see from the timeline. Regarding the F2726A, it was dissolved in saline and administered 3 days before oxaliplatin vehicle administration and following for further 21 days. This compound was administered 2 hours after oxaliplatin treatment by oral gavage. The day before the first oxaliplatin administration, behavioral tests were performed to set the basal value of mechanical and cold allodynia, and then again on 3rd, 5th, 7th, 10th, 14th, and 21st days. To assess for changes in sensation and in the development of mechanical allodynia, sensitivity to tactile stimulation was measured using the dynamic plantar esthesiometer, which is an automated version of the von Frey assessment. The rat was placed in a plexiglass box covered with a plastic dome that enabled the animal to walk freely but not to jump. When the trial is initiated, the device raised the filament to touch the foot of the animal and increased the force until the animal withdrew its foot or until it reached the cutoff of 50 Gs. At this time, the dynamic plantar esthesiometer automatically records the force at which the paw was withdrawn. In parallel, cold sensitivity analysis was performed and reported as the number of paw withdrawal after the application of acetone on the surface of the paw of the animal. As you can see from the graph, in control animal, the one that received only the vehicle, the black circle, paw withdrawal responses remain unchanged during the whole experimental period, while in oxaliplatin-treated animal, the gray squares, the paw withdrawal responses were altered due to neurological toxicity. Specifically, in mechanical allodynia, the paw withdrawal threshold was strongly reduced at 14 and 21st days, while in cold allodynia was persistent from day 3. Interestingly, DF was able to counteract oxaliplatin-induced mechanical and cold allodynia. The activation of microglia and astrocytes in dorsal root ganglia was evaluated through the expression of IBA1 and GFAP by Western blotting. As you can see, the chemotherapeutic agents significantly increased both IBA1 and GFAP, while in the presence of DF, the levels were comparable to those of control. We then evaluated TRPM8 and TRAPA1, and also in this case, the oxaliplatin increased the level of both ionic receptor channel, while DF was able to counteract this effect. Since intraepidermal nerve fiber loss has a crucial role in the development of numerous neuropathies, including chemotherapy-induced ones, we evaluated by immunofluorescence in the animal paws the marker of intraepidermal fibers, PGP 9.5, reported in green. I don't know if you can see here, I cannot see anything. As you can see from the figure, in oxaliplatin-treated animals, there is a strong loss of intraepidermal nerve fibers extending from derma into epidermis, while DF was able to preserve intraepidermal fiber integrity. Interestingly, the chemotherapeutic agent strongly increased interleukin-8 in the animal paws, while DF was able to attenuate this phenomenon, thus suggesting a neuroprotective effect against on nerve fibers. Finally, acetylated alpha-tubulin was evaluated, a marker of stable microtubule, and also in this case, even not significantly, the level of acetylated alpha-tubulin were increased by the chemotherapeutic agents, while DF counteract this effect. Since the in vivo results were encouraging, we tried to dissect the underlying mechanism using an in vitro model of neuropathic pain. In particular, we used NGF differentiated F11 treated with oxaliplatin. In a first series of experiments, cell viability assay was assessed in this sensitive neuron. As you can see from the graph, both DF and oxaliplatin were ineffective in modulating neuronal cell viability at the concentration range between 1 and 20 micromolar and 5 and 40 micromolar. Thus, for the following experiment, 1 micromolar was the concentration chosen for DF and 20 micromolar for oxaliplatin. We then evaluated acetylated alpha-tubulin by immunofluorescence and Western blot analysis. As you can see from the figure, control and DF-treated neurons barely express acetylated alpha-tubulin. In contrast, oxaliplatin-treated neurons strongly expressed acetylated alpha-tubulin. Specifically, the fluorescence intensity was increased, the neurite diameter was greater, and the cytoskeleton organization was more evident, thus suggesting that this compound, interestingly, oxaliplatin plus DF treated neurons, acetylated alpha-tubulin was strongly reduced, thus suggesting that this compound was able to counteract the chemotherapeutic effect. We then investigated on the effect of DF on the active form of the protein of focal adhesion, PFAC, which is involved in microtubule stabilization. And as you can see, the chemotherapeutic agents strongly increase the expression of PFAC, while the presence of DF, the level were comparable to those of control. We then evaluated the active form of JAK2, which is involved in STAT3 signaling, relevant for synaptic plasticity and neuropathic pain. Also, in this case, the chemotherapeutic agent was able to strongly increase the level of this protein, while DF restored control condition. Finally, P2AK-P-cortaxin pathway was evaluated, which is involved in synaptic plasticity and axonal arborization. And interestingly, DF was able to counteract the increased protein level induced by oxaliplatin, thus suggesting that the F compound was able to counteract chemotherapy-induced neuropathic pain. Since MAP kinase are also involved in neuronal toxicity, we tried to dissect also this pathway, and we analyzed the active form of ERK1/2 and AKT. And as you can see, the chemotherapeutic agent strongly increased the expression of both of this protein, while the F was able to counteract this effect. Finally, COX-2 expression was also increased by the oxaliplatin treatment, while in the presence of the F, the level were comparable to those of control. Overall, our findings indicate that interleukin 8 and its receptor CXCR1/2 are critically involved in the development of neurotoxic activity associated with oxaliplatin, and that interleukin 8 blocking by the F2726A significantly counteract their effects both in vivo and in vitro. Taken together, the results of our mechanicistic studies suggested that interleukin 8 expressed in peripheral neurons may trigger a neuroinflammatory reaction, leading to neuronal sensitization through the activation of key pathways involved in microtubule stabilization, axonal arborization, and neuropathic pain. Also, the progressive accumulation of interleukin 8 may be partially responsible for the intraepidermal nerve fiber loss occurring upon chemotherapeutic treatment. In summary, we demonstrated for the first time the involvement of interleukin 8 signaling in the development of chemotherapy-induced neuropathic pain, and thus interfering with this signaling using the novel compound DF2726A may be a useful strategy to alleviate chemotherapy-induced neurotoxicity. I would like to thank my supervisor, Professor Anna Maria Cimini, and Dompe Farmaceutici, and I would like to thank you also for the attention. Thank you.
Thank you, Vanessa, for the clear presentation. And I think that chemotherapy-induced peripheral neuropathic pain is a very important clinical indication. So I think that deserves very important studies in understanding potential way of management, but it's also an important model in this case to better understand the role of inflammatory mediators and chemokine receptor, in this case, expressed on peripheral neurons. So this is something relatively new. There are papers on MCP1 receptor expressed on peripheral neurons, and your work highlights the role for interleukin 8. This is something that is happening to us. We are more and more investigating the role of these mediators in cells that are outside the immune system. I have a question specific on the model. You showed an increase of IL-8 levels in the context of the animal model, in which you showed the reduction of fibers in the tissue by immunofluorescence. Do you know which is the source of interleukin-8 in the context. Inflammatory cells either, or other cells are responsible for IL-8 production there.
We are talking about the peripheral, so is the PO. So is the increase is in the direct in the PO. I can postulate that the involvement is mainly peripheral. But this is an important point because I read several reviews in which, since we are using chemotherapy for treat cancer and then trying to develop, trying to avoid the devastating side effects occurring in this patient. The important point is that modulating and reducing interleukin-8 is also valuable for reducing the invasion and migration of tumors. So this is really important, and thank you for the question.
No, it's a good point. And so I think that this kind of research will guide us in finding. There is a question, maybe.
Thank you.
I think it's very appealing now to have molecules like that working on the receptors, cytokine and so on, these peptides which are anti-inflammatory. In a world where a lot of monoclonal antibodies have very massive complications and very, expensive. So I don't think there's a big future for that anyway. Apart of this, my question is, did you analyze also the change in the other cytokines, pro or anti-inflammatory, at the level of the blood or whatever, also in the skin, for example, or outside of it?
Thank you for the question. This is a really interesting point. However, it is in our checklist. We didn't do at the moment. Thank you. Yeah, this is a point that we need to focus on. Thank you.
So we can start with the last presentation, still in the same field, the role of inflammatory mediators in the context of neuropathic pain. This presentation will be given by Cristina Giorgio. She's connected now. And Cristina Giorgio is a research scientist in my group in Dompei. She's working in our labs in Naples. She joined us, she's a very young researcher. She joined us in 2018. And she earned her PhD in Van Vitellit University at Naples. She has international experience in the Netherlands before joining us, and she's following with us a career in the preclinical pharmacology for pain and oncology. So that's why she will give a presentation on the most recent results of our results, in this case on C5a receptor and pain management. Thank you, Cristina.
Thank you, Dr. Allegretti, for introducing me. Can you see my slide?
Yes, perfectly.
Okay, great. First of all, I would like to thank the organizers for inviting me to talk at this meeting. Today, I'm going to talk about the role of C5a receptor as a target for managing neuropathic pain. Before starting, I would like to disclose that Dompei is interested in the development of C5a receptor inhibitors for the treatment of neuropathic pain. Just 2 words about neuropathic pain. As you well know, it is defined as a chronic pain state initiated or caused by a lesion or disease of central nervous system or peripheral somatosensory nervous system. It can result from different stimuli such as physical trauma, infection, inflammation, chemotherapeutic agents, surgical procedures, or autoimmune diseases. The symptoms can include shooting, burning pain, tingling and numbness, and all of these symptoms can lead to depression, anxiety, and low self-esteem. Nowadays, the treatment requires a multidisciplinary approach, including medication, such as anticonvulsant and antidepressant drugs, physical therapy, psychological intervention, and surgery. What is the role of complement system in the genesis of neuropathic pain? Complement system is a key component of innate immunity since it plays an important role in inflammation and in defense against common pathogens. C5a is the most potent inflammatory mediator produced by complement cascade, and it is the common component of all pathways in complement activation. C5a presents both immunoregulatory and pro-inflammatory biological activities by binding two known receptors, C5a receptor 1 and C5a receptor 2. We focus the attention on C5a receptor 1 axis because the role of C5a receptor 2 is still controversial. And the dysregulation of C5a receptor 1 axis can drive several pathologies, including neuropathic pain. So discovery and development of selective C5a receptor 1 inhibitors is therefore an active area of research. Specifically, C5a receptor signaling activation in both peripheral and central nervous system is involved in neuroimmune interaction that generate neuropathic pain. C5a is produced at nerve injury site, dorsal root ganglion, and spinal cord, triggering leukocyte recruitment such as macrophages and T cells, and drive neuropathic pain. Here in this slide, you can see several reports that highlight the important role of C5a receptor axis in the genesis of neuropathic pain, and all of these findings of these studies suggest that the inhibition of C5a activity by C5a receptor antagonists could be a potential therapeutic approach, a new application in neuropathic pain control. The most studied C5a receptor antagonist is PMX53. It is an irreversible C5a receptor antagonist, and it has completed phase 2 trials for the treatment of rheumatoid arthritis. A number of phase 1 and phase 2A trials were initiated for the treatment of age-related macular degeneration, for the treatment of dermatitis and psoriasis. But all of these studies, all these trials failed to reach the primary endpoints due to low bioavailability, efficacy, and tissue penetrance of PMX53. So novel compounds can be developed to improve the safety characteristics of PMX53, such as avacopan, that is a small molecule, an oral antagonist of C5a receptor, and it is the first Food and Drug Administration approved C5a receptor inhibitor for the treatment of anti-neutrophil cytoplasmatic antibody-associated vasculitis. However, avacopan has not been investigated in the context of pain. Actually, no preclinical and clinical studies were performed in the context of pain. So a novel strategy could be to design, discover, and develop new allosteric modulators of C5a receptor with improved drug-like properties, improved safety characteristics for neuropathic pain relief. We obtained promising results with DF2593A, a novel potent allosteric inhibitor of C5a receptor. The F2593A was originally identified as a selective de novo non-competitive allosteric inhibitor of C5a receptor by a medchem approach based on chemo and bioinformatic platform targeting G protein coupled receptor, including C5a receptor. In vitro, the F2593A strongly reduced the C5a-induced migration of human and rodent neutrophils, And moreover, the F2593 did not affect the number of C5a molecules on cell membrane and did not alter the binding between C5a and C5a receptor. After that, we investigated the effect of the F2593A in a specific model of neuropathic pain, the spared nerve injury model, that consists in a lesion of common peroneal nerve and tibial nerve, leaving intact sural nerve. This model closely mimics alterations and sensory symptoms of clinically described neuropathic pain disorders. And as you can see in figure A, the back triangles, the oral administration of the F2593A 7 days after spared nerve injury, which is the time in which pain is well established, strongly reduced mechanical hyperalgesia, and this effect persists at least 6 hours after treatment. After that, to confirm the role of C5a receptor axis in the genesis of neuropathic pain, we used the C5a receptor knockout mice. And as you can see in figure B, mechanical hyperalgesia was strongly reduced in C5a receptor knockout mice compared to vehicle, the white circle. And the treatment with the F2593A did not produce any further effects compared to the vehicle group. After that, in a therapeutic settings, the F2593A was administered from day 7 to day 14, as you can see in figure C, and the effects on mechanical hyperalgesia were immediated and were maintained for all observational period. Actually, mechanical hyperalgesia returned at the same level of control group 2 days after the suspension of treatment with the F2593A. So, based on these promising results on the F2593A, additional chemical and pharmacological studies were performed and led to a characterization of a second generation of C5a receptor allosteric inhibitors and the selection of a new lead compound, the F3966A, with optimized pharmacokinetic and safety profiles, but with the same biological activity and selectivity previously observed. At this point, we investigated the effects of the F3966A in a chronic constriction injury model of neuropathic pain that consists in ligature of sciatic nerve, and this model recapitulated symptoms similar to clinical neuropathic pain, such as spontaneous pain, mechanical hyperalgesia, and allodynia. And as you can see in the figure, the treatment with the F3966A 7 days after surgery significantly reduced both cold and mechanical allodynia at 1 hour and 3 hours after treatment. After that, we also investigated the effect of the F3966A in a model of chemotherapy-induced peripheral neuropathy, specifically paclitaxel-induced peripheral neuropathy. As you can see in the chart, paclitaxel were administered for 4 alternative days, and the F3966A was orally administered from day 1 to day 14, and the cold and mechanical allodynia were measured at days 1, 3, 5, 7, 10, and 14. As you can see in figure A and figure B, the black triangles, the treatment with the F3966A strongly reduced both cold and mechanical allodynia induced by paclitaxel, suggesting that C5a receptor 1 axis is crucially involved in chemotherapy-induced peripheral neuropathy onset and development. After that, We also investigated the effect ex vivo of the F3966A, specifically on the expression of chemotherapy-induced peripheral neuropathy markers such as TNF-alpha and the expression of C5a receptor. As you can see in the figure, the F3966A treatment strongly inhibited the increase of C5a receptor 1 induced by paclitaxel in spinal cord. And moreover, the F3966A strongly reduced the increase of TNF-alpha expression induced by paclitaxel in spinal cord. Finally, we evaluated the effect of the F3966A on DRG neurons treated by paclitaxel. You can see in the figure the electrophysiological recordings of DRG treated with paclitaxel in combination with the F3966A, DRG challenged with C5a and challenged with C5a in combination with the F3966A. And as you can see in the figure, the treatment with the F3966A strongly restored altered electrical activity induced by paclitaxel in the DRG cells, and moreover, the F3966A strongly counteracted the increase of electrical activity at short-term time points and blocked its reduction at long-term time points in the DRG cells treated with C5a. So in conclusion, take-home message that C5a receptor signaling activation plays an important role in neuron interaction involved in the genesis of neuropathic pain. C5a receptor axis can be considered a promising potential therapeutic target for neuropathic pain management. And moreover, pharmacological inhibition of C5a receptor axis by C5a receptor allosteric modulators such as the F2593A and the F3966A can be an efficient therapeutic strategy to control neuropathic pain onset and development. However, the challenge is to evaluate new drugs targeting C5a receptor pathway in clinical trials investigating neuropathic pain. Finally, I would like to thank the preclinical pharmacology and toxicology team. As you can see in the picture, next to me, my mentor and manager, Laura Brandolini, the Research and Discovery Director, Andrea Ramini, my colleague, Pasquale Cocchiaro, Marcello Allegretti, that is with you, and thank you for your attention.
Thank you, Christina. Again, at least from my point of view, a very interesting presentation on the crosstalk between inflammatory cells and peripheral neurons. So very important hints on pharmacological target. We are over time, so I want to hear if there are questions in the room. If not, I still want to outline again how important is this field, because of the up to not many years ago, we have considered C5a and C5a receptor as a very important target for the management of inflammatory pain, chronic inflammatory condition. And it's interesting to see how the deep understanding of the signaling mediators involved in the development of neuropathic pain lead us to become more and more familiar with the concept that the neuroinflammatory pain is now emerging. So it will be more and more difficult to make clear-cut distinguishment between neuropathic pain and inflammatory pain. So, and now we have molecules with anti-C5a in the clinics, in the market, both antibodies and different classes of molecules. It's not the topic here. We believe that allosteric modulation is an important opportunity, and we want to contribute to this field. Giustino has
Thank you. Dr. Allegretti, I have a general comment on the important session that you have chaired till now, because in 2017, the International Association for the Study of Pain has established the Year Against Acute Pain. And one of the conclusions of all the scientists involved in the study of pain for several years, like, for example, Tony Dickinson, just to make a name, that yesterday gave a fantastic lecture to this audience. One of the general comments was, we do not see new drugs on the horizon, but we should learn how to use better the ones we have. Now, today, I realize that we have new drugs on the horizon because there are new possibilities and new potentialities to develop new drugs, studying more carefully this kind of receptors and mechanisms of actions for the neuropathic pain. What is your impression for the future?
I fully agree with your comment. So I think that for a certain time there was a certain discouragement in the pharmacology and industry to lead new programs targeting with new pharmacological mechanisms for the treatment of neuropathic pain. The evolution of the knowledge is very important, and a strict dialogue between clinicians and pharmacologists will lead to new programs. But I also agree on what was the outcome of the panel discussion you mentioned. We have both the opportunity to better use all drugs. So this was an example of the given in the presentation by Professor Aurelia. So we still need to better interpret and understanding the potential of drugs already on the market that can be differently used. Same for C5a. We have molecules approved for ANCA but it's something that is there with a safety well clarified that we can explore in different indications. So we can explore new strategy, and I believe that with the better dissection of the pain condition, we as company will be more and more incentivized to move forward with programs for the patients. But I'm very optimistic on that. Thank you very much. Thank you very much.
Okay, thank you. So, it is now my honor and big pleasure to close this interesting experience of the hybrid Congress, which was, as I said before, a big challenge, and I must be very grateful to all the companies that have accepted to support this scientific communication in this new formulation, because this is very important. We are more and more used to have some webinar, which is definitely a situation sometimes very tricky. But a huge congress like this one, it is a bit difficult to have this combination of an hybrid formulation for the management. And I am extremely personally, on behalf of the foundation, the Paolo Procacci Foundation, I am extremely happy of the results because, as I said at the beginning, we got 1,230 registrations online, and we also got some registration in presence. I think that the beautiful weather in Rome and the appealing city that we are in has contributed to have very little people here in presence, but at the same time, I am very impressed with the results of the online presences, because this morning we had over 600 people connected, and till now, today is Saturday, and I imagine that many of our colleagues that are around the world are enjoying the family and their personal business. But till now, we still have over 400 people that are connected with us. So it is really a big pleasure for me that this Congress was, and it is still a success, in my opinion, my personal opinion. We will see, of course, we will see the feedback in the future of the results that we have with the messages we send. There is another important aspect, in my opinion, which is very crucial in the scientific communication. We are normally transmitting scientific messages and implementing new ideas and new ways on how to afford our patients at the end. And especially for pain patients, as I said just 2 minutes ago, we need new solutions, new strategies, new drugs, and new way on how to manage them. And I think the presence, like it was yesterday, for example, I was discussing with several friends outside and colleagues on new strategies and new modalities. The presence is absolutely crucial, because we can transmit very important scientific messages with the internet, but definitely we do not have the human exchange, which is absolutely important also for the scientific communication. New ideas. Last night I was talking with some friends and we got new ideas which should not have been happening if we would not have been in presence. So I think that the in-presence events are absolutely crucial for a better evolution of medicine in general, but especially of pain medicine, which is a very important topic, at least for my personal behavior and experience for all my life. So now I would conclude first presenting the scientific committee has analyzed all the abstract that we have received, and we do not have some of the presenters in person here, so we decided to just communicate the name of the 3 winners of the best communication, which are Chun Feng Cao. Dr. Cao is working in Xiao, and he has one of the winners of this best abstract presented for this Congress. We will, of course, we will deliver this at home of Dr. Cao. Next time, we hope that he will be here with us. And this is the award certificate for the telecamera. So Dr. Cao will definitely enjoy to see his name here and his certificate of winning this important prize. So the second one is an Italian colleague who has also presented an abstract with Antonio Corrente. This is the certificate, and we thank you for the applause for this presentation. The third one is a colleague from Egypt, that is Abdallah El Sayed Alam. Dr. Halam has apologized very much because he wanted to be here with us, but at the end he did not have the possibility to get his visa, and he has, of course, he is really sorry, and for sure he will be with us next year for the coming edition of the Congress. Dr. Alam is especially involved in pain management with physical activity and with interventional activities, modalities. So this is I want to thank the three of them because they have presented very interesting communication. You can find all the communication already published since a couple of months on the academic website of the Paolo Procacci Foundation, which is one of the initiatives of the Paolo Procacci Foundation in combination with the Cureus, which is a very well-known scientific journal. And now it is my big pleasure and honor to discuss a little bit about the Stefano Ischia Prize. The Stefano Ischia Prize was an idea that came out after the unfortunate departure of my mentor, I feel sorry because I'm really emotional on this because I had a special relationship with Stefano for several years. You are now looking at the images of Stefano in different congresses. Here you have Stefano Ischia together with Professor Carli that is still with us today. In one of the first Congress we had together, it was in 1988 in L'Aquila, the Congress of the Italian Pain Association. Stefano Ischia is one of the most renowned scientists in clinical pain in Italy because his approach to pain patients, and especially to cancer pain patients, was absolutely unique. Still today, we miss people that are so informed and so experienced in the management of cancer pain all around the world. He has published hundreds of papers with, in the most important journal on pain management, and Stefano Ischia was a very peculiar person. I feel honored today that we have with us also the wife of Professor Ischia, and it is for me a big honor to have the possibility to establish this annual prize in the memory of Stefano, because he deserves to be reminded to all of us for what he has done in general in medicine, but in detail for the pain medicine. He has been the president of the Italian Pain Association for 6 consecutive years, and he has really represented a light that was followed by many of us, especially of young people, like many of my residents and students. Stefano Ischia had established the first and unique residency course in Italy for pain management. But now we are still discussing if it is necessary a subspecialty in pain management. Well, in my opinion, the clear vision of medicine that Stefano had for several years had already suggested him that this was not only necessary, but it was indispensable. In fact, in the 80s, he had established this residency course in the University of Verona, which has remained unique in the history of the Italian Academy, especially addressed to pain management. this was an initiative that, unfortunately, for several regulatory problems, did not have a continuation. And now the specialization on pain management is still together with anesthesia, which is a good thing, but at the same time is a limiting thing, in my opinion, because it is not giving the right direction to the multidisciplinary approach to pain, which is, in my opinion, very, very important. Stefano Ischia had a brilliant, extremely brilliant career. He was a full professor of anesthesia at the age of 32 in Verona. At that time, Verona was just a new university coming from the University of Padua, as a derivation of the University of Padua, and he immediately gave this direction to his life toward the pain medicine. And this is why I think that he deserves all our attention and all our honors. And my personal experience with Stefano was really something special, because we met for the first time in '85, and he immediately established a really sincere and deep relationship with me, because his character, as it is said in this picture, his character was a really incredible character for a person of his position. He was a person that was devoted to donate and to give to the others. He was a real giver. And with this approach, he took me under his protection, in brackets, I mean academic protection, and he was responsible for most of my academic career. So I personally am extremely grateful to Professor Ischia for what he has done for me, and I was extremely sad at the end of November when we lost this incredible personality in the medicine, and especially in pain medicine. So the Paolo Procacci Foundation for this has decided to establish an annual prize for in memory of Stefano, and I am very happy that this will be given for the first time in the presence of Mrs. Ischia, which is with us today, and she will give the last prize at the end. But before that, I want to make clear what is this prize for. This prize is for the best presentations given by young scientists under 40 during the Congress. And it is my pleasure and honor now to invite Dr. Castelli, Vanessa Castelli, who has been awarded with so she will receive the prize by Professor Carli, and I would invite Professor Carli to join me here. Thank you very much. It is really a pleasure to have with us Giancarlo Carli. Giancarlo Carli is one of the founding fathers of the Italian Pain Association. He was also one of the first members of the ISP, And he is really a good friend, and especially he was an excellent friend of Professor Ischia. And that's why I am honored that he was here with us to present this award. And the first award was for the basic research, but the second one is for clinical presentations. And it is my big pleasure to invite Professor Zis, who even if he is a very mature researcher, he is still less than 40, and I would invite Arianna to join us here for the presentation of this award, please. So, with this, I feel, again, very happy for what has been done in these last 2 days. And I wish that we will have the opportunity to meet again soon, but in presence of many more people, and to have the possibility to exchange new ideas and to increase what we know about the pain management and the pain patients. So, again, to thank to all of you for being here present, but especially thank to all of you that are online with us. And I wish all of you a good, successful weekend and relaxing weekend.